Dear colleagues, it's my honor and pleasure to start our first own symposium of Young Scientist Council of Bechtereva National Medical Research Center for Psychiatry and Neurology. And I think that it is a real challenge for each of us to speak in English about our scientific research, but we should do this. We must use our English like our native language. So we'll try to do it today. And we will keep our timeline. So I think that it's time to greetings from our chairpersons. So the first word for our guest from Moscow, Sergei Potanin.
Thank you. Yeah. Dear colleagues, I'm Sergei Potanin. I work in Mental Health Research Center in Laboratory of Psychopharmacology, and I'm a chairperson of Russian Psychiatrist Society. So with
not the whole society.
Not the whole society. Speaking now. Okay. With Young Scientists Society. Counseling. Yes. Thank you.
Okay. And now, Igor Chumakov.
I'm very happy to be here, and I'm happy that early career psychiatrists are doing best to achieve their goals, to be part of science world and to be part of international world. And making a short reference to the yesterday plenum, when one of the speakers mentioned that English is the language of international research communication. I totally agree with this point, and I think that this symposium will benefit from bright and courage early career psychiatrists who and early career researchers who will present their results, and also will benefit from the audience who will understand that it is not something that you should be afraid of speaking in English, and it's not something that you should be afraid to present your own research, and also that this experiment of early career Council of Bechtereva Research Center will expand, and we will have more congresses and conferences with available English-speaking sessions. And I also hope that this symposium will be in only friendly environment, and this is not like a challenge, but a way to improve our skills, to have nice feedback, and also to start something new. And it is always good to start something new. So I wish all the participants luck, and give the floor to our next chairperson.
Thank you, Igor. Dear colleagues, I want to congratulate all of you because we did this symposium despite of the circumstances or everywhere. And I want to tell you that for me, this is a big deal and big data, because big day, because you are my friends, my colleagues, and I'm very happy that all of you came here today, and I will be happy to hear your presentations, your studies, and let's start work.
Yeah. We have a very big program, we have a timeline, and I think that it's time for our first speaker. I also hope that we will have very fruitful discussions after each speech. For each person, we have 15 minutes for lecture and 5 minutes for discussion. So the first speaker is Grigory Rukavishnikov. He is the Senior Research Assistant of Bechtereva National Medical Research Center. And the lecture is perspectives of autoimmune markers research in depression diagnostics. The floor is yours.
Thank you. I'm not sure if it is working, but I'll try to do my best. Just testing. Okay. So thank you so much again, dear colleagues. As far as we know, inflammation is an essential pathological process which is aimed to protect our body from different types of damage. However, in some cases, if inflammatory processes are not properly controlled, the results could be devastating. And we can see it, for example, in uncontrolled systemic inflammatory reaction, for example, like in novel coronavirus infection, in cytokine storm. And in some cases, our own immune cells could affect our tissues or other organs and thus lead to different types of autoimmune diseases. In central nervous system, inflammatory processes can proceed acutely or chronically, depends on the stage and on the type of damage, and include many different various mechanisms and elements. The main question which we need to ask ourselves today, and which is important to us as a psychiatrist, how can we use these inflammatory processes and these inflammatory markers to understand psychiatric disorders? And I think there are two main points here. The first one, is identification of potential markers to assess and control the patient condition and to select individual types of therapy. And the second point is to find new potential neurobiological targets for new therapeutic interventions. Different elements of inflammatory processes in the central nervous system could be used as our research basics. For example, immune cells, which could cross the hematoencephalitic barrier from the periphery or be secreted by different types of neurons and immune cells inside the central nervous system. And these cells are monocytes, macrophages, all the basic cells of immunity, and they could be produced by different types of neurons like microglia or astrocytes. Another important part of inflammatory process is cytokines, which are large protein molecules secreted by immune cells or by nervous cells, speaking about central nervous system. And they bind to specific receptors and provide different signals, which could be pro-inflammatory, speaking, for example, about interleukin-1/6 or human necrosis factor, or has an opposite anti-inflammatory purposes like interleukin-4 or 10. However, the interesting point is that some cytokines, especially, for example, interleukin-6, in different obstacles could play controversial role and be both pro and anti-inflammatory at the same time, depending on the stage and on the type of inflammatory process. Okay. Speaking about mood disorders and especially depression, today we know that cytokines play a significant part in the pathology of depressive processes. During depression, it was shown that there are significantly increased levels of pro-inflammatory cytokines and their soluble receptors in peripheral blood and cerebrospinal fluid. Also, there is significant increase in other indicators of acute inflammation, like acute phase proteins, chemokines, adhesion molecules, prostaglandins, and you name it, many other inflammatory things. Also, there were animal models of depression symptoms and inflammation, such as injecting different types of lipopolysaccharides. The mice lead to increase in pro-inflammatory cytokines and modulation of depressive symptomatics. The greatest interest in cytokines are paid in scientific literature to the elements of innate immunity. That's logical because these elements are quite similar for individuals, and we can do more stratified research in this area. However, more and more works appear about the properties and functions of acquired immunity and its role in depression. These studies are more complicated, however, they appearing more and more and in recent scientific literature. How does inflammation affect the nervous functions and behavioral function, and how can inflammation in the central nervous system lead to potential psychiatric symptoms? It is by affecting, I think, every significant system and three most important basic symptoms of central nervous system, like neurotransmission, neuroendocrine functions, and neuroplasticity. By affecting neurons, inflammatory elements could lead to the activation of tryptophan metabolism in the kynurenine pathway. And as far as we know, it leads to decrease in serotonin, the most basic and well-known mechanism for depression, and increase in kynurenine, which further leads to increase in glutamate, which during the chronic phase of inflammation would be damaging to neurons and lead to their destruction and apoptosis. Also, chronic inflammation affects the functions of hypothalamic pituitary axis with increased secretion of cortisol. However, during prolonged inflammation, the levels of cortisol would exhaust and significantly decrease. And the long processes lead to depletion of the function of the neuroendocrine system. And as I mentioned before, neuroplasticity is also a significant element. More inflammation, more damage to neuron cells, more apoptosis, more potential damage to different neuronal structures, more psychiatric systems, including anxiety and depression. Here we can see the illustration of the concept which I was speaking on the previous slide. As we can see, even the peripheral inflammatory processes could lead to changes in neurotransmitters metabolism, metabolism of tryptophan, decrease in serotonin, increase in glutamate, with damaging of neural structures, which leads to more inflammation, and in that way some sort of vicious circle is formed. Also, another important problem is why some, potentially all, we can have different inflammatory processes and different inflammatory problems in our organisms, why in some individuals they are associated with depression and in some they are not. The point here is that there could be initial predisposition to significant inflammatory reaction, perhaps even genetic ones, while during the effect of different external stresses, so for example infections, individual can have an increased inflammatory response, which leads to immune cells activation, which leads to further increased response to another infection or stress later, and another vicious circle is present here. Then every next stressor will bring more and more increase in inflammatory processes, more neuroinflammation, and more psychiatric pathology later. Here, I just want to share with you just a tiny little bit of our own research. It's actually nothing yet to see it here, and we hope yet, because the project is still ongoing. And our aim is to understand how inflammatory markers could be how they would be specific and sensitive in comorbid depression and autoimmune disorders. For that purpose, we are studying and evaluating patients who are present with most common types of autoimmune inflammatory disease, like rheumatoid arthritis and systemic lupus erythematosus. At the moment, 71 patients was evaluated, and we saw that the level of mood and anxiety disorders were quite high moderately high, almost 27%. Our patients were evaluated with a battery of different psychometric scales and inflammatory laboratory panel of different inflammatory markers. And at the moment, I just share with you a little bit of correlations, because all more complex statistical research will be proceeded later when our sample will be enlarged. But at the moment, we find maybe not very big, but interesting correlations with lymphocytes and leukocytes. Why it is interesting? Because it's in the opposite direction, speaking of correlation, and more information appeared in scientific literature that not only the number of cells play a significant role, but their composition and interaction with each other. And while lymphocytes and then percent was associated with increase in anxiety symptoms, the number of leukocytes was increased with the negative correlation, which could be a potential key to further research. Other possible promising directions in evaluating inflammatory markers in mood disorders and depression could be in harmonization of the study samples, considering the potential difference, like the stage of the disease or potential external factors or damages. We also could study specific changes in cytokines and maybe other markers for different mental disorders, because till now we are not sure if, for example, inflammatory profiles are similar. For example, for schizophrenia and at the same time for bipolar disorder, they could be different, and each mental disorder could have its own neuroinflammatory specifics. And also we should consider systems that are becoming more and more popular in many areas and could be associated also with both nervous system and inflammation. And for example, microbiome seems to be quite promising strategy and quite a promising link between these two components. Anyway, there are still a lot of things to learn and a lot of things to understand to better assess this problem and apply it to our clinical practice to help our patients. So we are looking forward to new horizons, and thank you so much for your attention. Wishing you all the best. If you have any questions, I will be happy to answer them.
Thank you. Thank you, Grigori. And I hope that audience online or offline have any questions. Yeah, please.
Okay, thank you, Dr. Kalishnikov. I really liked your presentation. In your opinion, is there any broader future for using anti-inflammatory drugs for depression treatment in not so distant future?
It depends on the distance of the future. Yes, but I think it's quite a promising strategy, because we already have some data that different types of anti-inflammatory preparations are helpful as adjunctive treatment for antidepressants. And there are studies for specific antibody compounds, which also could be used. We still have a lot to learn in this area, such as will these drugs work for every type of depression or only for specific depressive types, like treatment-resistant depression, when we, for example, have increased inflammatory component, and the etiological effects of these drugs will be more prominent in that cases. But I think that the future is bright for this collection.
I have a question. How can you explain the I forgot the word. The association between anxiety symptoms and biomarkers, correlation between these?
Okay.
And depression?
Yeah, I see. As far as we know, that anxiety is strongly associated with hypothalamic pituitary axis, and this axis also is essential part of inflammatory process, and it's very sensitive to different types of stresses. And for example, external stress could lead both to increasing cortisol and for example, anxiety systems. And at the same time, different changes and reactions to external factors and damages and react in that way as inflammatory process. So I think it would be one link of this association, but also there are different systems which are involved, and this could be effects on the structures of the brain, for example, amygdala, which would be also involved, for example, in some types of chronic inflammation, and the increase in lymphocytes could be the sign of continuing chronic inflammatory process, because the lymphocytes are often associated with chronic processes. So this chronic inflammatory process could also affect the neural structures and lead to potential
Yes, we know that.
symptomatics.
I'm sorry for interrupting. We know that chronic inflammatory processes are associated with depression more than with anxiety.
Yeah. Perhaps, but I'm not sure that anxiety is less prominent in chronic depression, but there was a hypothesis about neuroendocrine function in a prolonged period of time. And the point is that in the initial stages of depression, we have the increase in cortisol levels because it's initial activation of hypothalamic pituitary axis and its first reaction. However, during, as I mentioned, the chronic types of inflammation, the levels of cortisol are depleted, and that leads to chronic depression symptoms and less anxiety. That would be one of the explanations.
Thank you.
Thank you.
Thank you. And okay.
Thank you for your amazing presentation and comprehensive view on this problem. Are there any differences between different subtypes of depression in inflammatory profile? Have you ever seen this information in different articles?
Unfortunately, no, but I'm thinking that there's a perspective of further research and also a perspective of further research for our own department.
Good deal. And the last question from chairperson.
I have really two questions. Maybe
Okay.
they will be short. First of all, what is EAT26? What about?
It's the screening scale for eating disorders.
Eating disorder.
Yeah, eating attitude test. It's completed by patients. I will be talking about it in the Russian speaking session a bit later. The point is that they feel different questions about eating behaviors, and we can screen for the possibility of eating disorders.
And the second question is, do you have your own experience with patients, not of course with rheumatoid arthritis or something, with pure psychiatric disorders, where you used maybe celecoxib or other anti-inflammatory drugs?
Actually, we had a clinical trial in our center some time ago. It was about, I think, celecoxib. In treatment-resistant depression, it was used as adjunctive therapy to the course of main antidepressant, 3 injections in a period of 3 months, as far as I remember. And the inclusion criteria were increased levels of C-reactive protein. So the sample was not very big because many patients did not meet this criteria. However, some of our patients received this treatment, but because the sample was very small and we could not deny the placebo effect because it was a clinical trial, it's difficult for me to speak about the efficacy of this treatment.
Thank you.
Thank you. Any questions from online? No?
No.
Okay, thank you. Thank you, Grigory, and
Yes, thank you, Grigory, for a nice presentation, and thanks for the audience for really interesting questions. And I'm happy that we have a discussion this early morning, and we are ready to give the floor to the next speaker, Sergei Potanin. He already presented himself, but I repeated that he is a psychiatrist, PhD, and the head of Early Career Psychiatry Council of the Russian Society of Psychiatrists.
Thank you. Dear colleagues, it's yes.
Yeah.
It's working.
Okay.
It's not working.
I like it.
Dear colleagues, it's very nice to meet you. Thank you for the opportunity to speak and to show our results of our study. It's not only my study, of course, it was multi-central study. I will talk about this in this presentation. The main idea, not about this study, but mainly about what we do as our laboratory of psychopharmacology. Now we are trying to study the impulsivity as transdiagnostic syndrome. So we see, for example, like cognitive deficit is transdiagnostic syndrome. We see it in schizophrenia and affective disorders and so on. So we think that impulsivity is something like this. So this is a symptom that we can see in affective disorders, in personal disorders, and so on. And the main point is that impulsivity can be the symptom that is more important for functional patients than the traditional symptoms that we see. So if, for example, going to our study to speak about patients with bipolar disorder, we see that, of course, we all know that impulsivity is one of the main symptoms of mania or hypomania or mania. But as we can see in the studies, it's also very important in depressive state. Of course, it's important in mixed states, and it's for some patients, not for all patients, but for some patients, it's one of the main problems in remission, even in remission. And the other point is that impulsivity is the thing that may be, as I spoke before, the main problem for functional patients. For example, patient don't have depression, he don't have hypomania, but he fights, he drinks, he have risky aggressive behavior, and the patients or his relatives will come to you and say, "Doctor, you have a problem with your patient." Even he is not considered as depressive or mixed or in hypomania or mania. So, as to speak about, sorry for this overloaded slide, but I will explain shortly. This is the studies which were conducted in comparing bipolar patients in different states with controls. On Barrett Impulsivity Scale, I will talk about later what is the scale. It's the main instrument for measuring the impulsivity at this time. So as you can see, the interesting point is that there are mixed results. It's not working, but underlined numbers, it's that studies where there was no difference between patients and controls. But as you can see, in other studies, there are differences. And so the first 5 studies is patients in remission. So it's patients where we don't see any depression or mania, and they still show high impulsivity if compared but not in all studies. Of course, if we see mixed studies, it's also always a area of interest. So we should explore its further studies. So, if to go to our study, totally there were 32 patients with bipolar affective disorder, any type, in remission. We have some small subgroup of 7 patients where we did the fMRI study. And the main inclusion criteria were main supportive surgery, so we used as add-on study, as add-on agent quetiapine in low dose, 25 to 75 milligrams. Of course, it's not dose that can be some stabilization therapy or anti-manic therapy or antidepressive therapy for bipolar disorder. It's really adjunctive in low doses. So the main inclusion criteria was bipolar disorder remission, stable therapy. Exclusion criteria was harsh and unstable somatic disease. Of course, patients who already took quetiapine, they are not included in study. And we excluded patients with depressive or manic states, and we did the MADRS and YAML score to see that it's really so. And we also did we registered this protocol on clinicaltrials.gov. It was interesting experience to conversation with these people that are just for every point or every letter about protocol and so on. It was a very interesting experience. Speaking about assessment, about key points and assessment. So key points was based on the instruments that are gold standard for today in speaking about measuring of impulsivity. So the basic measurement is Barrett scale. It's questionnaire. It's questionnaire for patients. It's about 30 points there. So patient check some checkbox, and there are some speaking, for example, do you really can spend a lot of money, more than you usually use? And can you think about stability of your work and so on? So patient shows that he is as he thinks like this behavior, or this behavior is not usual for him. So there are 7 points. So if you see 70 points or more, it means that patient have clinically significant impulsivity. If you see 70 or 69 or less, it means that patient don't have significant impulsivity. This instrument is translated and validated in Russia, in Russian language by Nikolopov, our colleague from Mental Health Research Center. So it's definitely a reliable instrument. The other two, Go and balloon and risk test, is its tests, its task. So in Go, you should press the button when you see one thing. It may be some, for example, when we used, it was emoji. So there are tests where patients saw the instruction, you should push the button when you see emoji with smile state, and if you see any other emoji, you should not push the button. So it's defined on can you stop or not stop your pushing the button. It's correlated with impulsivity. Another, the balloon risk task is very interesting test, really. So patients see on the screen the balloon, and they have a button that will pump it up. So push, and the balloon is going bigger. For every push, you earn 5 points. So 1 push, 5 points, 2 push, 10 points, and so on. But in very random moment, and there are no correlations, it's just random. The balloon can break. and you lose all points that you earned on this balance. But at any moment you can press button save points, and all this will go to your safe place, and this is stable points, and you see another balance. So it's a very difficult task for balancing the risks, and also it's one of the validated instruments for impulsivity. So the key points was significant changes on these instruments. About the procedures, so Barrett impulsivity scale, Gemmer's mothers at the screening, balloon ring tasks, and altogether treatment was 6 weeks. So add-on therapy was 6 weeks. It was conducted in 4 centers, our center, your center, and also Medical Academy and in St. Petersburg and Kansas State Medical University. So it was open label, multi-center, add-on study. Why we choose the low doses of quetiapine? First of all, it's speaking about tolerability. It's very good in speaking of tolerability, and also it's very balanced. It's very balanced drug for dopamine and serotonin activity, based on its mechanism of action, and for tolerability it was chosen. There was a small group of 7 patients where we conducted fMRI, and the fMRI was made with also go-no-go task. So patients were conducting the fMRI with a button where they should do some tasks. They see squares, they push buttons, they don't see squares, some other figures they don't push buttons. So it was on our tomograph, 3 Tesla Philips. It was very hard to make it because it always it's very complicated thing, and it's very often broken. So you start, you take patients, you call to fMRI, they say, we don't work on us, we have broken. So we conducted with the Kirov Academy. They said, okay, let's start. They start the patients, and then I see, they call me and say, our fMRI is broken. So it was very hard. But 7 patients, they were all on our 3 Tesla Philips apparat. Main results. So we conducted,
includes
two of 3 main key points were made. So we see the significant change on Barrett scale on bar test, but not on go-no-go. Maybe we didn't exactly took the right thing from go-no-go, because the prime may be not very, the parameter that will change on 6 weeks. But 2 key points were reached. So if to speak about more clinical seeing of patients, we defined our patients, some of our patients, as responders. We are speaking about clinically significant. So there's something yet you can see in clinical, not only in points or numbers. And we defined it as first as 2 keys. First of all, it should be 10 or more points decrease on the Barrett scale. And second, they will must be forced to see a patient as a responder. 10 points or more on decrease, and okay, and going under the 70 points, because of course we should see one that it's a very big dynamic, and the other point that patients don't have impulsivity. So as we see, the response rate was 50%. That of clinical significant result is really that you can see in your eyes, but not only in numbers. So in the fMRI, we see not very big results, of course, because there were only 7 patients. All you can see is that we see that in a difference in connections, that some regions of brain were more significantly connected with others, and it was correlated with lowering of impulsivity. So for conclusion, the impulsivity is a significant problem for bipolar disorder in remission also, and quetiapine is one of the prospective medicines for this. Of course, there should be placebo-controlled studies to see if it's real or it's just because of small sample and placebo effect. Thank you.
Thank you.
Thank you, Sergey. We have a few minutes for questions. Do we have questions?
I think I have. Okay. Please no.
Audience, please.
Thank you so much for your talk. As you mentioned, I think it's not problem only in non-functioning, functioning MRI, but as one of our foreign colleagues told me, to put bipolar patient with manic symptoms in MRI is already a heroic act. So thank you for this complex research. But in the very beginning, you mentioned also that impulsivity could be personality trait. And what do you think about that? Will quetiapine be useful as maybe some sort of treatment for impulsivity as a personality problem?
Yes, there are studies of quetiapine that showed improved in impulsivity in patients with borderline personality disorder. It's
Only
published.
borderline or maybe in other types?
In other types, I don't know. I saw this study. It was a relatively big study, placebo-controlled, I said.
Yeah, thank you, Dr. Batanin. It was a real pleasure. I have a question about responders and non-responders. Did they differ in maintenance therapy? I don't know, maybe non-responders have different drugs or lower doses, something like that.
No, it's not because mainly all patients, except 3 patients, took only mood stabilizers and antidepressants. So mainly we can see that quetiapine in the most of patients was the only one antipsychotic. And if you speak about was the difference between some patients took 25 or 75 in quetiapine, no, it's...
No. I mean other drugs.
Other drugs, yes. They were quite similar.
Ah, okay, thank you.
Quite similar.
Thank you, Sergey, for your perfect presentation. I have a question about fMRI. Can you tell me, may other factors despite quetiapine influence to the results of MRI of the patient? As I understand that you did the fMRI before treatment and in time of treatment, yes? Or not?
After 6 weeks.
Okay, so could any other factors influence to the results of MRI?
Definitely.
And what are they?
If we are speaking about a sample of 7 patients, definitely it could be.
What are they possible?
Just different circumstances in work, in family, in stabilization, in speaking with us.
Yeah, I mean that the fMRI is quite not stable methodic here, and a lot of different facts of life can influence.
Of course, and, it's a problem because small samples. We are trying to be make the sample bigger, but of course with only 1 point because the study is over it. But we are still seeing the patients with bipolar disorder in remission, and we are just interested in a difference between brain activity in patients who have impulsivity and the patients who don't have impulsivity, and we are conducting the study.
Thank you.
Thank you. Any questions from online?
No.
No? Okay, thank you.
I would love to introduce the next speaker, Natalia Surakova, senior researcher of the Department of Treatment Patients with Exogenic Organic Disorders and Epilepsy, PhD, please. The study of markers of the neuroinflammation in patients with epilepsy.
Good day, Alex. Thank you, Bechtereva, for introducing me. I'm a neurologist, and area of my interest is epilepsy. And today I would like to talk about neuroinflammation, about the role of neuroinflammation in pathogenesis of epilepsy. So, what is it, epilepsy? According to the definition, International League Against Epilepsy, epilepsy is a disease of the brain characterized by repeated epileptic seizures as a result of excessive neural activity and has various clinical manifestations, as well as neurobiological, cognitive, psychological, and social outcomes. There are many causes of epilepsy, but this is based on hypersynchronization and hyperexcitability of neurons, dual pathology of neuronal membranes, and disbalance between excitatory and inhibitory systems. In 2015, ELI update criteria for diagnosis of epilepsy, and diagnosis of epilepsy can be established if one of three criteria on this slide is met. If patient had two improved epileptic seizures with an interval of more than 24 hours, or one improved seizure, and change of repeat seizure is more than 60%. For example, patient have one seizure, and after examination, his EEG result show epileptiform activity, or maybe MRI results show high epileptogenesis changes, for example, hippocampal sclerosis, and these changes indicate a high chance of repeated seizure. And third criteria, diagnosis of epileptic syndrome. There are about 50 million people with epileptic seizure in the world. Epilepsy is widespread, and the third most common neurological disease. In recent decades, great progress has been made in the treatment and diagnosis of epilepsy, but about 13% of patients have drug-resistant epilepsy. It's not only medical, and also is social and economic problems, and this requires the improvement of therapeutic diagnosis and rehabilitation measures, and search new pathogenetic and therapeutic targets. At present time, the role of inflammatory process in the pathogenesis of epilepsy is actively discussed. Currently, there is much experimental and clinical evidence of a new inflammatory theory of epileptogenesis and dysregulation of inflammatory cytokines in epilepsy. In particular, the association of increased levels of pro-inflammatory cytokines with risk of seizures. The inflammation in the in the central nervous system is based on damage of blood-brain barrier, and this causes a cascade of immune-dependent reaction, leading both to induction and of epileptic process and its progression. Various disease, example for head trauma, infection, stroke, leads to change, increased permeability of blood-brain barrier, neuronal cell, or neuronal hyperexcitability. This change leads to actogenesis and epileptogenesis, and this established the basis of onset of epilepsy. But epileptogenesis and actogenesis can activate immune mechanisms and involve inflammatory cells from periphery from the damaged blood-brain barrier. As a result, neuroinflammation is fixed. Cytokine regulating the process of inflammation can have both pro-convulsant and anti-convulsant activity. And pro-inflammatory cytokines inhibit the intake by astrocytes of glutamate, which causes increase in extracellular glutamate concentration and glutamate excitotoxicity, which leads to hypersynchrony and excitability of neurons, and the creation of conditions for a predictable state. In our center, we conducted an immunological study, and the aim of the study to investigate the cytokine status in patients with epilepsy with different variations of the disease. Okay. We started pro and anti-inflammatory cytokines in both groups. First group included 160 patients with epilepsy. Second group, 30 healthy donors. The patients with healthy donors without seizures at anamnesis and at present time and in anamnesis. The patients with epilepsy were divided into two groups, subgroups, patients with drug-resistant epilepsy and patients with controlled epilepsy. Pro and anti-inflammatory cytokines were analyzed in blood and cerebrospinal fluid of patients, samples of patients with epilepsy, and just in blood samples of healthy donors. The results of the study showed that plasma concentration of pro-inflammatory cytokines interleukin-1 beta, interleukin-1 beta and interleukin-6 and 8 in group of patients with epilepsy significantly increased those of healthy donors, and while the concentration of anti-inflammatory cytokines, receptor antagonist interleukin-1 beta and receptor significant interleukin-2 receptor significantly decreased in the group of patients with epilepsy compared to the group of healthy donors. And this indicates a disbalance of cytokines toward increased of pro-inflammatory cytokines and decreased anti-inflammatory cytokines in patients with epilepsy. And special attention is paid to the pro-inflammatory cytokines interleukin-1 beta, where experimental and clinical data of the effect of interleukin-1 beta on the epileptic process. And interleukin-1 beta is expression of astrocytes and microglia in the central nervous system. And interleukin-1 beta changes blood-brain barrier and neuronal excitability by increasing glutamatergic transmission, and has pro-convulsive effects. And recent studies have shown that interleukin-1 receptor, anti-inflammatory, are localized the pyramidal cells in the hippocampus on NMDA receptor, and these play an important role in the occurrence, start and spread of paroxysmal activity. In our study, we also obtained data on the disbalance of interleukin-1 beta family in the compared group, epileptic patient and healthy donors. Plasma concentration of pro-inflammatory cytokines interleukin-1 beta was significantly increased in group of patients with epilepsy, also healthy donors, and concentration of the anti-inflammatory cytokines receptor antagonist interleukin-1 beta significantly decreased in blood plasma and was determined in the cerebrospinal fluid of patient. But the concentration of pro-inflammatory cytokines interleukin-1 beta in cerebrospinal fluid in a group of patients with epilepsy was higher, that this concentration interleukin-1 beta in group of healthy donors in blood plasma. This leads to the conclusion that in epilepsy there is a disbalance between pro and anti-inflammatory cytokines of interleukin-1 beta family, and in favor of pro-inflammatory cytokines. Considering the significantly difference in the level of cytokines of interleukin-1 beta family between compared groups, we assumed that these cytokines may be informative for different variations of epilepsy. And we investigated interleukin-1 beta family cytokines in two subgroups of patients with drug-resistant and controlled epilepsy. And result, a study showed that the concentration of pro-inflammatory interleukin-1 beta was higher in the group of patients with drug-resistant epilepsy in both plasma and cerebrospinal fluid. And the plasma concentration of anti-inflammatory cytokines antagonist interleukin-1 beta rail-1 beta in cerebrospinal fluid of patients with drug-resistant was low, and no determinate in cerebrospinal fluid in patients with drug-resistant epilepsy compared with controlled epilepsy. So the received data confirm this balance of pro and anti-inflammatory cytokines in epilepsy with the maximum severity in patients with drug-resistant epilepsy. They confirm experimental data of the role of neuroinflammation in pathogenesis epilepsy, and this finding highlight for potential new target for therapeutic opportunities. And thank you for your attention. I wish you wonderful time in our beautiful city, which was built by Peter Lebed and had he had epilepsy, and maybe his disease and personality changes associated with epilepsy help him build our city.
Thank you.
Thank you.
Thank you, Natalia, for your interdisciplinarity spirit of your speech with history, with neurology, of course, with biochemistry, and any questions for our speaker? Yes.
Thank you, Dr. Sakova. It was a real pleasure. Well, my question is, were there any attempts, maybe in some articles and literature, to use anti-inflammatory drugs as an adjunctive treatment for treatment of epilepsy?
Yes, thanks for your question.
have like an open microphone.
Yeah, of course.
Anyone who wants to join the discussion and have 3 minutes to present their own results or project. It's very
Elevator test.
yes, it's very nice format when you have only 3 minutes and you need to present your idea and sell your idea to the audience, and then the audience want to be involved in your study. Then you get financial support, then you get research support, then you are the champion, and your study is published in the one paper. So you have a chance to show your idea to the audience of our not only on-site audience, but also for online audience. So, no one?
I have a question to Grigory Rukavishnikov.
Yes, please.
Grigory, can we find any association between headache, neuroinflammatory, and depression?
Okay. What type of headache? Migraine? Any specifications like migraine, tension headaches, cluster headaches? Because I think it would depend on the exact type and the exact mechanism of the headache, and of course we can find an association in that case. But different types of pain, different mechanisms, I suppose, and also different mechanisms of depression could be involved. For example, in migraine, it's as far as I know more about vessels, and in cluster it's about neurons. So maybe some aspects of pathological processes could be different, but the basic associations could be similar for all these mentioned conditions.
Thank you.
Thank you. Can we hear Maria?
Everything working. So
Hi.
Yep.
Hello, Maria. It's your time.
So I am online,
Your turn.
right? Thanks. Just didn't want to intrude too early. So can you hear me well?
Yes.
Brilliant. Okay, let's just pray that everything works. So I'm just going to share my screen now. And okay, and fingers crossed that nothing goes wrong. So
Yeah.
do you see, no, you don't see my screen yet. Only the green one. How about now? Can you see my screen now? Yes, you can, I guess. Yes. Okay. Brilliant. Sorry about this. Not super familiar with the technology. All right. So, may I start?
Yes, please.
Okay, thank you so much. Okay, so good morning. I guess it's morning for all of us now. Good morning, everyone. My name is Maria Bechtereva, and please let me introduce myself. So I'm just recently finished a PhD at the Department of Old Age Psychiatry at King's College London, and I'm now transitioning to a postdoc position. And I currently also work at the as a research associate at the Bechterewa Institute, and I'm really proud to be here today, and really grateful for being invited here today. So the title of my talk today would be the role of plasma inflammatory markers in late life depression and conversion to dementia, and I'll present the results of a 3-year follow-up study. A few words about the abbreviations that I might be using, that you might be encountering on my slides. So MDD is obviously major depressive disorder, LLD is for late life depression, LOD is for late onset depression, EOD is for early onset depression, FU signifies follow-up, and AD is for Alzheimer's disease. So I understand you're not really familiar with my work, so let me say a few words about what I've been working on for the past 4 years. So basically the major focus of my work is studying the links between late life depression and dementia and subsequent cognitive decline. Why is this relevant at all, you'd ask? Well, there's plenty of studies, including plenty of meta-analysis, that would show you that depression, a depressive episode occurring in later life, up to the age of 60 or 65, is strongly associated with an increase in the likelihood of subsequent dementia or cognitive decline as measured continuously. So that's more or less a proven fact. There are some difficulties in understanding the mechanisms of this association. So while it seems to be true for both early onset depression, and by early onset depression, I mean depression with a manifestation of the first episode, say before the age of 60, and the recurrent episode in later life, and late onset depression, where the first episode of depression occurs after the age of 60 or 65. So while this seems to be relevant for both phenotypes, there may be different mechanisms involved. I won't go into detail about this now, as this is a very long talk. If you're interested, we can bring this up during the Q&A. So besides, it's well known, we think we've mentioned that today as well, that both depression and cognitive decline are extensively linked to inflammation, and there are a number of potential links. We can also discuss the potential mechanisms linking these during the Q&A. I have some slides on that, some extra slides. Inflammation may both follow and contribute to the pathology of Alzheimer's disease. So the question that I wanted to address was whether plasma inflammation could predict the progression from late life depression to dementia. A few words about how I arrived at this hypothesis. So like when I was doing my literature review at the very beginning of the PhD, I saw several interesting publications that showed that a number of proteomic factors, including some inflammatory factors, may mediate the relationship between depressive symptoms and dementia. There's two studies that I really like by Royal et al. And Gallagher et al. And then, unfortunately, well, like the third one, there's only 3 relevant studies so far as far as I know. The third one, published in 2020, did not show an effect of plasma cytokines on progression from late life depression to dementia. However, the study was performed in type 2 diabetes patients, so this could be a separate category. But my results, spoiler, were also negative, but we'll talk about it later. So what cohorts did I use? An overview of the cohorts that I used. So there were 2 cohorts generally. So the PRODE, which stands for a prognosis of depression in the elderly, was the clinical cohort, which included 169 patients with late life depression at baseline, of whom 96% were admitted to hospital. The final cohort of that I used for my studies was 152 patients because the other 17 proved to actually be demented at baseline. And these patients were followed for, I think there's a typo here, for 3 years. So we had some data on at year 1 and year 3. And this cohort was developed by my dear colleague, Dr. Tom Borza from the Oslo University, and he was the principal investigator. A very similar closely linked cohort, however considered as separate, is called the Cognorm cohort, and this is a cohort of age-matched participants, which was developed by Dr. Leif Otto Wagner, and these were the elderly participants without depression at baseline, and only 8 of them had a prior history of depression, and those were excluded during the sensitivity analysis, and this showed no major effect on the results. So these patients were also followed for 3 years. However, my study was split in 2 parts, a cross-sectional part and a longitudinal part. So cross-sectionally first, I compared late life depression and controls with regards to the concentration of plasma inflammatory markers. So there were 136 patients with late life depression and 103 cognitively normal non-depressed controls. And the following array of cytokines and chemokines were measured, which you can see on the slide. I won't go deep into the details of the analysis, but I did two types of analysis for the cross-sectional study. So I did the multiple linear regression with cytokines as outcomes, and then I split each cytokine values into high degree and low degree inflammation, and I performed binary logistic regression with depression status as outcome. So each biomarker was dichotomized at the median. And yeah, of course, I bumper on adjusted the significance level, and let's take a look at what the results were for this cross-sectional part. So in fully adjusted multiple linear regression analysis, there were 5 markers that were different between late-line depression and controls. So patients with late-line depression had markedly increased levels of CCL2, CCL4, interferon gamma, IFN gamma, IL-17A, interleukin-17A, and interleukin-1RA. And in the second part of the analysis, the second one showed that higher levels, so high degree IL-1 array and IFN gamma concentrations independently predicted depression status. So this was a sort of a confirmatory, the second one was sort of a confirmatory analysis to look at things from a different angle, because I like to run several models to make sure my results are robust. So a few words about what these things actually are. So the CCL2 and CCL4 are chemokines. They're also known as monocyte chemoattractant protein 1, MCP1, and MIP1 beta, and they were shown to play a role in neuron glia communication, synaptic transmission, neurogenesis, etc. And there have been 2 meta-analyses that show that higher CCL2 was associated with general MDD, not late-life depression. And there was also 1 meta-analysis that showed that lower CCL4 was characteristic of MDD. However, no previous studies of late-life depression as far as I know. So this was the first one to show they're elevated in LLD. Interleukin-1 array is it's an inhibitor of the activities of interleukin-1, and it may prevent basically an anti-inflammatory cytokine, which can prevent the detrimental effects of interleukin-1 beta. And there's also been evidence of its elevation in MDD in general, not in LLD specifically. And we all know, I guess, that depression is very common in patients treated with interferon. Interferon gamma is a cytokine which is critical for innate and adaptive immunity, and it's the IDO1 inducer. There were, however, previously conflicting results with regards to the differences, to the direction of the differences in major depression. In our analysis, elevated values of the cytokines were associated with late-life depression. And 17A is also pro-inflammatory cytokine, also quite novel data, because only 1 study previously looked at it with regards to LLD. So in my second part of the analysis, I wondered if inflammation in late-life depression may influence cognitive outcomes, and in particular, may predict progression to dementia. So this study was only performed, I have to say that this study was only performed, sorry, I'm going to have to go back, I guess, in the PROD cohort, because in the cognitively normal participants, by year 3, there was not a single case of dementia. There were only 3 people diagnosed with MCI, with mild cognitive impairments. We had to stick to the depressed-only cohort in order to do this. So in our study, as it says here, no controls diagnosed by dementia. In our study, 36 depressed patients, or 26%, progressed to dementia by year 3. I find it actually quite amusing that in a different cohort, which I analyzed, the number of patients with late-life depression progressing to dementia over an average of 4 years of follow-up was also 26%. I love how these numbers matched. Anyway, I analyzed these with Cox proportional hazards regression, with dementia statuses at year 1 or 3 as outcome. And unfortunately, I have no pretty graph, no pretty picture to show you, because I did not find an effect of any of the baseline cytokine or chemokine levels on the likelihood of conversion to dementia at follow-up. So this part of the results was negative. There are, however, certain limitations to the study. First of all, as I said, we did not have controls progressing to dementia, so we had to stick with dementia, with depressed patients only, and we have to consider that those were mostly admitted depressed patients. So this was a population of a moderate to severe depressed elderly patients. Although there was quite a wide array of cytokines, there was, for example, no measure of CRP, which proved important in previous analysis. So this might be something to look into further. Also, we only had baseline levels of cytokines, and it did not allow to look at the trajectory of the change of cytokines and maybe the dynamics. And of course, you might wonder whether plasma measures are enough, plasma cytokine measures are enough to actually represent what's going on in terms of inflammation, while we know it's been shown that cytokines do permeate the brain-blood barrier. There's conflicting data at the moment with regards to whether plasma and CSF cytokine levels are comparable and whether this is a valid measure at all. So this needs to be looked into further. Finally, it could also be just low power, because despite there was quite a high rate of conversion to dementia, the sample size, although perfectly phenotyped, was still quite small. So perhaps larger scale studies are needed. So in conclusion, we did a cross-sectional comparison of late-line depression with controls, and we revealed significant differences in a number of plasma, cytokines, and chemokines. However, none of the inflammatory markers predicted further progression to dementia after 3 years of follow-up. I hope I did not exceed my time limit much. So thank you very much. Tusen takk, as the Norwegians say, because this is a Norwegian cohort. So yeah, I've learned quite a few Norwegian words over the past few years. Thank you so very much.
Thank you, Maria. Thank you for your speech. It's our third report about affective disorders, third report about inflammatory processes. This is the first report about longitudinal study and the limits of the study, of course. Yeah. So thank you. Questions from audience, online or offline?
No.
No?
Thank you,
Yes.
Maria. Tell me, please, what tools did you use to study cognitive disorder?
Oh, okay. Thank you very much for your question. So I actually did quite a bit of analysis with this cohort. This is just part of the things that I did. So first here, well, okay, so let's start from the beginning. First, all of them, of course, got MMSE at baseline and at discharge. And while at baseline, a lot of them, quite a few of the depressed patients had MMSE below 25. Most of them improved by discharge. One thing I did was I ran a sensitivity analysis by excluding the participants whose MMSE score did not improve after they received inpatient treatment, just to ensure that I'm not including patients who were in fact prodromally demented at baseline. So that's one thing. The sensitivity analysis did not change the results in any way. That's one thing. Another thing is, of course, it's dementia. Actually, I didn't mention this limitation. We only had all-cause dementia diagnosis. So this study did not distinguish between Alzheimer's dementia and vascular dementia. And I think this may also be quite a massive limitation, but larger sample sizes could be needed to actually distinguish between the two. And finally, which I did not present here, there was a neuropsychological battery assessing several cognitive domains. There was CRAD, COAT, trail making tests, and a number of other tests. If you would like more details, I'm happy to share them. None of the tests, so I also did a longitudinal analysis of cognitive functioning over time, over 3 years, in the depressed cohort and the effects of inflammation on the slope of cognitive tests, I also did not find an effect of the baseline inflammatory factors on any of the neurocognitive test scores over 3 years of follow-up.
Thank you.
Thank you. Any other questions?
I have one question.
Yeah, please.
Thank you, Maria, for your interesting presentation. And I know that was not for purpose of your study, but maybe you know the differences between a neuroinflammatory profile between patients with late onset depression and early life depression.
Okay, thank you. Actually, it also was a topic of my presentation. So that I did study that for sure. And if you give me a moment, I need to remind myself. Could I please just take a second, because I have my my thesis chapter opened here where I have all this data. So there were no massive differences, I gotta tell you. I think the most prominent differences were with regard to CCL2 and CCL4, where late onset depression patients had higher levels of CCL2 and CCL4 compared to early onset patients, and there were no other differences. Yeah, unfortunately can't find this slide at the moment, I'm sorry. While looking at it, we realized that the actual effect sizes were probably too small to seriously present this. So I'd say that mostly I did not find any differences. I do have quite a big interest in trying to see the differences in clinical cause, in cognitive outcomes between EOD and LOD. And in this study also, there was no difference between early onset and late onset depressed patients with regards to progression to dementia. So no difference whatsoever, whether they were early onset and late onset, similar rates of progression to dementia.
Thank you very much.
Thank you.
Thank you. Any other questions? Maybe one question from me. Maria, what is your point of view in using of anti-inflammatory drugs in psychiatry for nowadays? Is it prominent for use these drugs right now or not?
Thank you so much. Thank you for the question. Well, okay, so I might not be totally updated on everything in the field. From what I know with regards to specifically to affective disorders, there is not enough evidence, in my opinion, now to recommend this. So one study that comes to mind is the study from the ASPRI cohort in Australia, which looked at the efficacy of aspirin in late life depression and cognitive outcomes, and it didn't show any positive results. So, well, based on that, there may be some new studies that I'm not aware of, but based on that, I'd say I don't think it's time yet. Plus, you see the evidence with regards to the involvement of inflammatory factors is also quite contradictory, at least in my field.
Thank you. Thank you. So I think we should gratitude our speaker.
Thank you so very much. Now, how do I disconnect? Sorry. Okay. Oh, yeah, here.
Okay, and the next speaker is Kirill Fedorovich Valsilchenko, PhD, Assistant of Department of Psychiatry and Medical Psychology, Omsk Government Medical University. The presentation will be about the delay of language development prediction using artificial intelligence in children under 1 year old. Please.
Everyone, dear colleagues.
А вы презентацию скидывали?
Только мне? Окей.
Я сейчас скину почту, куда нужно отправить.
1 minute, please. Так.
Is it very hard with just basic medical education to start programming in Python, I think?
No, not at all, because Python is not actually, I mean, AI programming is not actually real programming. It's just if you have algorithmic type of thinking, it's okay for you. You can write everything you want.
So you don't have to have a PhD degree on math to use artificial intelligence.
Not at all. It's just kind of additional tool in your everyday scientific practice.
And why children?
Why children?
Yeah.
Just because I was looking for someone who have kind of huge database, and I don't care what kind of data I may work with. Just if I have a data, I can analyze it with neural network. Just, you know, I met Leonova. She presented and let me work with her database.
Yes.
Хотела предложить каждое заседание.
failure to distinguish bipolar from unipolar depression may lead to inappropriate treatment and poor outcomes. And of course, this is due to the prescription of antidepressants, because some patients with unrecognized bipolar disorder can not only produce hypomania or mania, but also mixed states or worsening of depression with increased risk of suicide or self-harm behavior. And this is a big problem, because in many cases, in real clinical practice, in many cases we don't recognize bipolar disorder. And first question is, why don't we recognize bipolar disorder? There are three main reasons. There are three answers. First, in many, if not most cases, bipolar disorder starts with symptoms of depression. And first hypomania or mania may not appear until years later. And second, previous episodes of hypomania or even mania may be missed in some patients. This is a story about false negative memories, and this is real problem. And finally, recurrent depression is considered a part of the bipolar genetic spectrum. These results we got from family and genetic studies. For instance, about 2/3 of unipolar relatives with unipolar depression of bipolar patients in fact had bipolar depression. This fact about overlapping between unipolar depressions and bipolar depressions. And the main question is, are there definitive criteria or biomarkers of bipolar depression? And unfortunately, no, we don't have any definitive criteria or biomarkers, but we have many clinical red flags. We have hallmarks of bipolar depression, which is replicated in different studies and in different countries, and this is very important for psychiatric science. And let's see them. First clinical feature of bipolar depression is the presence of mixed or psychotic symptoms or catatonia. Of course, mixed episode is equivalent of mania. We don't have a question in this situation, but if we see a patient with psychotic depression or depression with catatonia symptoms, we should exclude bipolar disorder. The next, atypical depression. Patients with bipolar disorder have a high rate of depression with atypical symptoms such as hypersomnia, hyperphagia, leading paralysis, reactive mood, and interpersonal sensitivity. This is very important. Next, liability, mood, and hypothymic temperament. And also, patients with bipolar depression have a high rate of early age of onset their depression, and they have high rate of seasonality pattern, and women have a high rate of postpartum depression. This is a very old fact, but it's necessary to recall about this. And also, a abrupt onset and offset. Also, patients with bipolar depression have more frequent and shorter episodes. About therapy, this is very contrast feature, because on the one hand, patients with bipolar depression have a high rate treatment resistance, and all cases of treatment resistance in bipolar depression, in all these cases, we should exclude bipolar disorder. On the other hand, patients with bipolar depression have a dropped onset response to antidepressant or increased dose. This is a switch, and this is very specific for bipolar depression. And finally, family history of mood disorders or suicide or severe mental illness. And family history is the most robust predictor of bipolar depression. especially in cases of early onset depression. And also family history of completed suicide along with male sex and the only known predictors of completed suicide in this group. This is very important for management of patients with depression and suicidal ideation or behavior. Okay, assessment of mixed symptoms. The challenge is that there is no accepted definition of mixed symptoms. Oops. The SAM5 mixed symptoms specifier is most restrictive diagnosis requiring at least 3 mixed hypomanic symptoms, excluding the overlapping symptoms of psychic or motor agitation, irritability and disirritability. However, these symptoms, along with the mood liability, the broader irritability, anger, hostility continuum, and impulsive suicidality, are considered the core of mixed state of many others specialists in bipolar disorder. And we should remember the main features of mixed symptoms in depression and mania, because if we have concerns about presence hypomania in patients with depression, these symptoms can help us to diagnose bipolar disorder. And finally, some recommendations for assessment and monitoring unipolar depression with the hallmarks of bipolarity, such as family history of bipolar disorder or suicide, typical symptoms, and so on. First, we should conduct careful assessment and follow-up of family history, and gold standard is a direct interview with relatives of patient. Second, we should conduct baseline and follow-up monitoring of both manic and depressive symptoms, weekly monitoring for 4 weeks and bi-weekly monitoring up to 12 weeks. This is according to Canadian psychiatrist Martin Alder, who is one of the main specialists in bipolar disorder. Okay, next, we can use the cultural medical history, which can help us to. We should pay specific attention to suicidality, including impulsive suicidality. We should pay specific attention to psychic or motor agitation because of mixed symptoms, and should follow course long term for alteration in course of illnesses. And if we have a problem with differential diagnosis, bipolar depression, unipolar depression, we can refer this patient in specific center, and it's the best way for this patient if we don't decide this problem. Finish. Thank you.
Thank you. So it's time for questions for our speaker.
Yeah, thank you, Dr. Garcia.
About inflammatory activity.
Yes.
Yeah,
for your color presentation, it was a pleasure to my me. Well, maybe I asked you this question before, but in your opinion, what approach is more efficient? Like, when we see a young patient with depression, with no history of manic or mixed episodes, but with some atypical features.
Yeah.
What therapeutic strategy is more efficient in your opinion? Like the presumption of bipolarity and treating it like bipolar depression, or presumption of unipolar depression and treating it like just major depression?
Unfortunately, we don't have guidelines for management patients with depression and high risk of bipolarity. I can share my experience. In most cases, I conduct psychoeducation about paradoxical reaction on antidepressants. and I asked question to send me mail after 1 week treatment about the psychic states, and yeah, there were exceptions when I discussed with patients about treatment, their treatment, and in most cases they choose mood stabilizers because of family history of mood disorders, because of atypical symptoms, because abrupt onset and offset depression. This is very specific for bipolar depression, and mixed symptoms are very important for diagnostic. And in these cases, I discuss with the patients their treatment, and they agree with me, and I choose mood stabilizer. This is off-label, of course. This is off-label.
Thank you.
Thank you. Other questions?
Yeah.
Yeah, I want to speak about typical reactions to antidepressants. Of course, switching cause effect is a definite thing, but I discussed one case of my patient. She was presented with major anxiety symptoms, mainly. And so I tried escitalopram, and she experienced very high hypersexuality on escitalopram. She described it as what I want 24 hours.
Yes.
And some my colleagues from Moscow told me that she's bipolar. And I said, why? Why she's bipolar? Because she has a typical reaction to antidepressant. What do you think? It's really the case of bipolar, or it's just a typical reaction to antidepressant?
If she had only hypersexuality, it was not a hypomania, but I provide structured interview during my consultation. I ask about all symptoms of depression according to diagnostic criteria, and these help me to diagnose hypomania or not. If patient has only 2 hypomanic symptoms, for example, irritability and hypersexuality, for example, no, I usually decide don't change the diagnosis of unipolar depression and continue using antidepressants. But I in most cases I ask my patient to send me a mail or come to consultation after 1 week or 2 weeks.
Okay, thank you. Questions?
A question
Yes.
online. What happens to the patient next?
I just changed to sertraline. At sertraline, we saw she described it like I tried amphetamines, and it's just like amphetamines. So then, just because I don't want to do, we switched to vortioxetine. It's not a drug for anxiety, definitely, but in this case, what to do? And with vortioxetine and tafazepam, it's okay. It's with no strange features.
Okay. Well, maybe in this patient it is indeed about bipolar, because like amphetamine intoxication is really like many stage. So maybe
Keep in touch.
Was right.
Maybe, but in catamnesis it was about 1 year, and she came with anxiety, with as I told, she came with anxiety. She was just on tremor, on just in the cabinet. So
it can be a linguistic problem. In Russian, I use words взбудораженность or взвинченность, and many patients say Yes, it's not anxiety, this is взбудораженность of зрительность. And in this case, I recheck all symptoms of current capacity.
Oh, definitely. Of course, it was a very long time to see hypomanic and so on, but no kids. And so on this, we with her psychotherapist finally agreed with diagnosis of attention deficit disorder. As a dawn, yes, it was attention deficit disorder with generalized anxiety disorder, comorbids. And when we see like this, and he tried to work as psychotherapy conducted on the attention deficit and some drugs on as stofazepam mainly on anxiety, patient was stabilized.
Hypersexuality is a type of hyperactivity. Yeah.
But it was only on escitalopram. We stopped escitalopram and it stopped.
That's joke.
Maybe this was escitalopram from North Star, Северная звезда.
No, it was the original drug.
Original. Okay.
Now we know that doing a report in English is much simpler than to practice as a psychiatrist in English. So
Thank you.
Thank you. And finally, with our apologize, we invite our speaker from Omsk, Kirill Vasilchenko, with his topic delay of language development prediction using artificial intelligence in children under 1 year old. Please, the floor is yours.
Okay, try number 2. Hello again. Before I start my presentation, I have to note that I'm not the only one author of this work, so the other one is here in this auditorium, Alyona Leonova. Thanks to her, it was this work became able to be came true. Well, before I start the presentation, again, I have to say that we have no conflict of interest when we conduct this study. What is developmental language delay? Developmental language delay is the qualitative and quantitative underdevelopment of the vocabulary, unformed expressive stage, the absence of the child's phrase by 2 years, and the absence of the child's coherent speech by 2 years. And as we may see, the DLD, let me pronounce this disorder as DLD abbreviation, the number of DLD cases through years is still increasing. So also we have to say that according to biopsychosocial model of mental disorders development, there are several group risk factors, several groups risk factors for DLD. First of them is biological group of biological factors. The attention should be paid to biological factors, to the presence of hereditary burden and parents' history. Second group of factors is factors that negatively affect the development of nervous system during pregnancy and childbirth, actually development of fetus. And the other group, the last one, is childbirth complications. The relationship between characteristics of the meltdown development of children and the gestational age of delivery is shown to be ambiguous. And we have to note that the impact of the main negative factors occurs at the age up to 1 year before the first words are appeared. Today, the machine learning, or ML, in its capabilities, the advances in the development of the machine learning, they actually have a significant impact on healthcare system. And also, I gotta note that the advantage of machine learning, one of the greatest advantage of machine learning, is that the machine learning algorithms are able to identify the kind of factors that could not be identified using just simple statistical methods. An example of highly efficient methods of machine learning is actually ANN, or artificial neural networks. Talking about ANN, or artificial neural networks, talking about ML, and if we apply the machine learning techniques to DLD studying, we may know that there are a number of studies that are about DLD and machine learning. For example, in the study by Borovsky, the search was made for the factors that have the greatest influence on the language delay, and they invented a machine learning algorithm that may predict language delay, developmental language delay. The other paper shows that there is a high efficacy of ML learning in prediction DLD, but with MRI pictures. And we have to note, and we gotta keep it real, that MRI in the beginning of the era of import substitution is still expensive, and there is a need to find a way to predict DLD without any equipment, without any expensive equipment. So we started. It's not clicking. I mean, it's clicking, but the slide doesn't change.
А он там отключен, показывает.
До этого переключался
У
вроде.
меня просто тоже было такое, надо посильнее.
Still not working.
Проводная, нет?
No.
Получается, да. Раньше закончил.
Maybe I have some kind of phishing or report technique.
It's artificial intelligence.
Yes.
The email was working.
It's Friday the 13th.
During
It's Friday the 13th.
Ah, yeah. Yes, there's a lot of factors.
Yeah.
Кому-то больше, кому-то меньше.
Well, before we are able to change the slides, I have to say that we're just at the beginning. We're just at the beginning of our study. So, and I have to say that the main aim of our study is to develop at this point, at this start point, any kind of artificial intelligence tool that be able to predict the DLD in children under 1 year old based on just anamnestic data, anamnestic data using ANM. Considering that we are at the beginning of our study, we hypothesized that the artificial intelligence is able to predict the DLD in children under the age of 1 year, in the future up to 3 years based on just anamnestic data. Talking about material and methods, we have to say that we collected data of 196 children. The mean age of kids was 26 and 9 months. All the sample was separated by two subsamples. First of them is children with DLD, and the second one, the children without it. All the data we collected, was collected with our anamnestic checklist. The checklist included questions about heredity burden, pregnancy, period of mother's life, and maybe fetus development issues or anything like that. And talking about just the period of child's life when the child is already born. The data included questions about or organic brain disorders and so on. All the data, a number of anamnestic information about early period of child's life in the development model was included in the model. And after normalizing, they collected data in array. Array is kind of tensor, or is kind of data that may be downgraded right into the neural network. And this data was normalized and included in our model. Looking at this slide, you may see this kind of strange picture. Well, it's just simple illustration. You may see that illustration of our artificial intelligence ANN algorithm. This algorithm is pretty simple. This algorithm called is feed-forward neural network. It's pretty simple. This this architecture was formed using the Python programming language and the Keras library for this language. To teach this artificial neural network, we have to spend about 1,000 iterations, or as we call it in AI development, 1,000 epochs. And the result is, the result is pretty tantalizing. We could reach the accuracy. Let me know what is accuracy. Accuracy is the percent or the volume of correctly identified cases. Well, 89% of cases were correctly identified. I also get a note that this, for artificial intelligence, it's pretty high value. To assess the real accuracy of the model, its sensitivity and its specificity, a ROC analysis was carried out. The area under the curve AUC was 0.99. Optimal cutoff point was at 0. Optimal cutoff point was at 0. Oh, it doesn't work in the screen. Okay, optimal cutoff point was at the level of 0.65, and the specificity is pretty interesting. The specificity and sensitivity of our model was 1 and 1.0 and 0.9. I think it's pretty high for this kind of simple algorithm. Well, considering that we exceeded the limit of presentation time too much, I have to finish my presentation. Not actually because it's finishing already, just because we have no much time. Well, in conclusion, I gotta say that the hypothesis we did was tested and it was confirmed. So for now, we actually know that the artificial intelligence, or ANN, is able to predict DLD in children under 1 year old, in the future up to 3 years, just using the anamnestic data. Thank you for your attention. If you have any questions that could be that may lead to exceed the time of my presentation, the limit of my presentation, you may ask it just via email me or second author, Alena Leonova. Thank you.
Thank you. Questions?
Yeah, thank you very much. These results are miraculous. But I don't know much about the child psychiatry, unfortunately. But my question is, if using the software, we know that the child will have a speech delay, and is there anything that we can do, or we just will know it? Are there any early interventions?
Of course, we may do something, but the aim of this part of this work is just, are we able to predict? If we are able to predict, of course we're able to prevent.
Thank you.
I have a question. First of all, I was impressed with the methodology, and I think that it is important to spread the word about these instruments more, especially in the field of early career researchers, because as we know, early career researchers are more able to and more open for new types of research. And in this case, my question is about, do you have any ideas or samples, according to the literature, where in psychiatry this methodology could also be used in order to have a line of researchers in our audience to collaborate with you?
Well, the answer for this question is pretty simple. Artificial intelligence may be applied, especially in psychiatry, everywhere. It's just the limit of our fantasy, and that's all. It may be applied everywhere. Just give me an idea. If you have any kind of any kind of node, that any kind of huge data, we are able to do something with it. We are able to find factors that no one was able, or still wasn't able to find. Well, maybe it's art of mental patients. It's our second work. Maybe I don't know, speech recognition of mental patients, or etc. Everything. The field of application of AI is pretty huge.
And what is the number of huge?
Thousands.
Okay. So first of all, you need to find data about thousands of patients.
But to be honest, look at this. Look at the number of the sample in this study. It's not huge. It's limited, pretty limited. But we could. We did just. I think the result is amazing. Yeah. We did amazing results. Of course, it's not applicable. Still, it's not applicable to health service, because we just have algorithm, and we have no tool, maybe application for the cell phone or service in the internet. But
I want to make it.
Yeah, we're gonna make it, but I think we have to. We just gotta try to get the higher level of accuracy. Why 80? Why 89? We need at least 88. At least 90, 95. Or not 100. It's impossible at all. But 95. Why not?
Thank you. Any other questions? Yes.
Thank you for your presentation. First question is, are there any limitations for using artificial intelligence in psychiatry?
Yes, the clearance of the data. Yes.
It's all? Is it all?
It's the main in. I know that this word doesn't exist, but it's the hugest issue. Considering the way that the data in psychiatry is collected.
Yes, okay, but why do you use this method of machine learning? Why don't you use typical regressions?
Mm-hmm.
Why?
Why? I say why not? I get your question. But there is a number of studies that use other methods, kind of regression or tree or anything like that. But we have to know that the other methods, other than ANN, they take a lot more time to learn, more time, days, weeks. This 10 minutes. The result we got is the result of 10 minutes learning, and it's faster.
Yeah.
And it's
faster
and just this is my second specialty, and just I'm looking for the way to apply this.
Okay, and will you use validation cover for this method, or?
Excuse me, I didn't get.
I start to learn machine learning,
yes.
And the main rule there are test coverage and validation.
Yes, yes. The result you see is the validation accuracy. It's not
validation.
No.
You have
validation and the to see.
You present one cohort with 98 patients in 98 health controls.
Yes.
It's one cohort.
Yeah, the covers is one.
Yeah.
One is, well, I have to.
Did you agree?
Yes, it was divided. As you as you know, in machine learning, it is kind of, we have to do something kind of, you know, make a placebo sample in, sleep, I mean, blind data. Well, the blind data was collected from this sample. Well, answering your question, yes, the result that you see is the result of we found on validated data, and the ROC analysis was conducted on tested data.
Test data. Okay. Yes. Thank you.
Thank you.
Thank you for a very interesting presentation, and I have such a question. I'm very interested in your methodology, and it sounds very great. And the question is, what factors can we use in this methodology? For example, can we use the retrospective data? Can we use the data, not just the numbers, for example, tests, or just anamnestic data, yeah?
Yes.
Can we use it, for example, in studying suicide risk or something else?
Of course, yes. We were able to use it retrospectively, but if we use it retrospectively, I mean, using it retrospectively, you are just creating the sample sample for learning, and after the algorithm is ready, after the algorithm is done, you're able to use it prospectively. Well, to use it prospectively, you have to learn retrospectively.
For example, if we're talking about the suicide risk, we can't use this data up to date because we can't predict the risk at the moment, just expected data.
Well, we have to test it in real life data, and we'll see what we got.
Okay. May I?
Yes, sure. Thank you.
Thank you for your perspectives that you have opened for us in our future research in artificial intelligence. Also, thank you very much.
Thank you for the invitation. Thank you for attention.
And we go to the other speaker. I'm happy to introduce you Marina Bechtereva. She's from Serbia right now. Yeah. But she works in laboratory for clinical pharmacology of addictive states in Institute of Pharmacology named after Waldman. And her speech dedicated pharmacological and psychological interventions in HIV-positive people who used opioids. So the floor is yours, Marina. Welcome.
Thank you. First of all, do you see me and hear me well?
Wait a minute, please. We should make our volume up.
The volume is at maximum level already.
Okay. So could you? Yeah. Thank you.
Okay. I will try my best. So first of all, hello everyone, and thank you for giving me this opportunity to present today. It's really pity that I'm not here with you in person, but I hope this not really influence on quality of presentation. So let me a little bit return you from very high level innovative methods to like more ground-based golden standards of clinical trials. So I today present you, my name is Marina Bechtereva, yeah, like I'm a dictionary psychiatrist first of all and researcher at Pavlov University. And today I would like to present you two studies which was done in my lab. And my goal of the presentation is to show you how two clinical trials with pretty similar methodology have a little bit different results and what lessons we learn from these two studies. Okay, let me figure out how it's work. Sorry. Okay, so first of all, I would like, of course, acknowledge that the work which I present is based on the work of the huge team from Pavlov University, from Boston University, Boston Medical Center, and we also work closely with Addiction City Hospital in St. Petersburg. And of course, I thanks to our study participants and all people who contribute on the conducting of these trials. So it's like well known that opioid use is not so popular as cannabis use, but it's still based on the World Drug Report. In 2018, the number of past year users was 58 million in the world. And Russian Federation, compared to other countries, has the highest country level disability adjusted life years per 100,000 population for opioid dependence. And it's comparable with the countries as Norway, US, Australia. And based on our official statistics, it looks like opioid use disorder, this problem is kind of solved, and the proportion of patients with OUD, opioid use disorder, decreased over years. But still, people who inject drugs and preliminary it's opioid are still key in vulnerable population for HIV, and HIV epidemic is still the case in Russia. And the biggest problem here that the IRT coverage, like antiretroviral coverage among people who inject drugs, is still very low, which show how these HIV epidemics are kind of uncontrolled right now, or like limited control. And for now, we know that there are like two basic addiction treatment approaches. First of all, it's abstinence approach. It's like our in Russia, this approach is like more popular when the goal for medical care providers is to achieve remission, to achieve stable remission when patients use zero amount of drugs. And the second approach is harm reduction, where the goal is less attractive and it's safe use. And the focus is to reduce negative consequences for health for people who have addiction disorders. And one of this is prevention of HIV. For now, we have pharmacotherapy options for opioid use disorders, and based on the approaches, abstinence or harm reduction, we use agonist or antagonist treatment. And naltrexone is only available evidence-based pharmacological treatment in Russia for opioid use disorder. And the previous study shows that it's safe for using among people who have HIV, but it can be challenging because for induction of naltrexone, there is need to be abstinent from opioids prior to initiation. And for most of the people, it can be challenging, and because it's required inpatient detoxification. But there are also the other things which we can do with people who have opioid use disorder and who have HIV, besides of pharmacological treatment of opioid use disorder. And it includes medical care, initiation of IRT, and the primary goal is achieving viral suppression when person couldn't transmit HIV to other people. And so with this background in mind, we conducted first randomized controlled trials among people who have HIV, who live with opioid use disorder. And the aim of the study was to compare and evaluate the effect of slow-release naltrexone plant versus oral naltrexone to improve treatment outcomes. So you're probably familiar with this abbreviation like PICO, which help us to understand what is the methodology behind of the clinical trials. So the population was people with opioid dependence. And I would like to point one very small but important details that we include the patient after they completed detoxification treatment. up to 1 month. And they have HIV with viral load up to 1,000 copies per milliliter, and they don't have experience of IRT before. It was 2 groups. Implant group received slow-release naltrexone implant every 12 weeks, plus oral placebo. And oral group received placebo implant, but per oral naltrexone. And each group consists of 100 patients. And we look, the other primary outcomes was time to relapse and how they retain in HIV care and adherent to ART. And here you see the Kaplan-Meier survival graph with log-rank test when we compare proportion of those who remain in addiction treatment for 48 follow-up period in both groups. And clearly you see that naltrexone implant group was more successful in terms of retention in addiction treatment. The similar results for HIV treatment. So primarily this study showed that naltrexone implant do better in terms of improve outcomes for HIV and for opioid use disorder for people with HIV and opioid use disorder. So like one pharmacological treatment works better for all treatment outcomes, which we interesting. But pharmacological treatment is not enough, and it's well known for people who involved in mental health area, I guess, and especially who work with people with addiction. And it was well stated by one of the fathers of methadone treatment, which is agonist treatment, that they also state that compassion and skillful counseling is needed and should be in adjunction to pharmacological treatment. And that's why we also conduct study when we see how aiding case management. Intervention case management is meaning that the person who have experience of opioid use disorder and who is at the moment achieve remission and don't use and kind of have some education, like for example psychological education or some skills to work in addiction field, and who have also HIV infection, and these kind of persons are called case managers. And they conducted some counseling to help people to achieve their treatment goals, for example, to start IRT. And we show that aiding this very kind of low-cost intervention show very great results on the terms of linking person who using drugs to start HIV care, to start being involved in HIV care. So logically, we started second randomized controlled trials when we use combination pharmacological and psychosocial intervention, and the treatment outcomes was pretty the same. We interested in opioid abstinence. We of course interested in undetectable viral load, but take your attention on the inclusion criteria. The inclusion criteria was we include person who have HIV and who was hospitalized at narcology clinic because they have opioid withdrawal. So we include them. We don't wait until they end their withdrawal treatment. We include them just at the moment they was hospitalized. So, and this is kind of the treatment intervention which this kind of study is more related to real life settings. So it's compared to first one, when it was more laboratory condition study, when we need person to successfully achieve abstinence from opioid and successfully completed withdrawal treatment. So, and as intervention, we use 3 components: case management, of course, pharmacotherapy, naltrexone implant, and we start ART initiation at hospital, at addiction clinic, which is also very important and was kind of difficult, but it's possible. But here you see the preliminary data, preliminary results is not published yet. So, but we can already get some lessons from the results. Only 60%, like less than 60%, start naltrexone, and this is intervention group. It was the group who was randomized in intervention group and who is supposed to receive naltrexone, and only 60% receive it. And you see during the follow-up, during 40 weeks follow-up, less and less people receive this actually. And still, we see some promising results. And compared to control group, intervention group was more successful in terms of suppressed HIV viral load. So based on these results, we see that, yes, compared to treatment as usual, combination of this pharmacological treatment, including antiretroviral treatment, naltrexone, and psychosocial intervention as case management, it might be effective strategy to achieve viral flow suppression among people who live with HIV and inject drugs. But we still have the problems. So the potential clinical effectiveness of naltrexone reduced by the problem that patients actually don't take the medication. And we see that many individuals who intending to start naltrexone don't do this. And we see it clearly in randomized controlled trials, number 2. And those who start naltrexone, they discontinue it in very short follow-up period. But our big hope that including psychosocial intervention might be very important additional element to the treatment, which can increase adherence to treatment of naltrexone and treatment of antiretroviral treatment. So this is the end. Thank you for your attention. I am ready for taking your questions.
Thank you, Marina. Time for questions, please. Audience is exhausted.
Yes. Thank you for your presentation. I just want to understand many individuals tending to start naltrexone. Only 60% have successful NXT induction. What does it mean?
Yeah, it means that the person who couldn't, like other 30%, they just couldn't completed their opioid withdrawal treatment for various of reasons. Someone have like high opioid craving and they just discharged from the hospital because they have this craving which they couldn't treat, and they just want to discharge against of medical advice from their doctors. And we in addiction clinic we see this all the time. Not everyone who hospitalized completed this withdrawal treatment. So, and that's why it's the second one is like real clinical situation, like real life clinical trial. Like, so, and it's actually just show you how the problematic, like one of the problem of how to make people actually can complete their withdrawal treatment and start the pharmacological therapy, which we have available in Russia for long-term.
So they just didn't start it, the naltrexone.
Yes, yes. And this is a very common problem.
Terminating is another problem. So
another problem? Sorry.
Prematurely terminating the therapy is another problem. It's different, two different problems.
Yeah. And the high dropout rate, we see this in both treatment, in both clinical trials. The first one, when we enrolled patients after they successfully completed the detoxification, we see high dropout rate. So this is how, like, but still we see actually results on our primary outcomes of intervention. So.
And I'm interested in just technically that 12 weeks, right? It works 12 weeks. It's prolonged form. Yeah.
Yeah.
And it's implant or like plastic. What is it?
No, it's implant. In Russia, we have 3 pharmacological formulations of naltrexone. It's per oral injection, and we one of the country who have implant. Like we also, I think Australia have implant for their clinical trials, but we one of the country who have implant naltrexone, which actually prolonged for 3 months, and probably no any other countries who right now registered as naltrexone implant. And mostly it's like Vivitrol, injection Vivitrol, which is only effective for 1 month.
Is it possible to eject this implant? Can patient just take it?
Oh, yeah, sure. Yeah, it's also possible. Yes, we know about these cases. Mm-hmm. Yeah.
Okay.
They can
Thank you.
it's yeah, this is the other problem. There are a lot of technical problems.
When patients use drugs like Travicta in psychiatry, they can do it.
Mm-hmm.
Okay.
Thank you for your questions.
Thank you. Are there any questions? One question, 2 questions from me, especially from Marina. What type of randomization did you use and why? And the second one, what was the effect sizes? Maybe did you analyze the number need to treat or any else?
No. So based on like first question, I don't remember right now all details, and I was I remember about like second randomization clinical trials, which we do block randomization with stratification based on the intensity of opioid use disorder, but because the intensity was like pretty the same, and they all like 98% of patients was with very intensive symptoms, severity of opioid use disorder. So we finally get out this factor as stratified, but we stratify, we use gender and antiretroviral treatment. Like if person have experience of having antiretroviral treatment before, it was the stratified factor. So we should be before randomization. Actually, the randomization goal was to be sure that in both groups we have enough similar numbers of those who have experience of antiretroviral before, and we should be ensure that gender proportion between these 2 groups was the same. So we use these 2. But for first one, I can go to details and return to these questions after a while if you're okay with it. And yeah, we actually don't we do intention to treat to treatment intent to treat analysis, and we don't do any additional study because it was like proposed in our first protocol, like, and it was registered in clinicaltrials.gov. So that's why we just don't do any additional analysis for this trials. So
thank you. Any other questions? Maybe from online? No? So thank you, Marina.
Mm-hmm.
Thank you so much.
Okay, I would like to introduce our guest, Olga Alexandrovna Guskova, junior researcher from Tyumen and clinical psychologist from Laboratory of Instrumental Diagnostics, with a presentation about quality of life in patients with COVID-19 associated pneumonia 3 months after hospitalization.
Hello, dear colleagues, dear audience. I'm clinical psychologist Guskova Olga. I'm glad to be here today, and I'm glad to present the results of our research. dedicated to the quality of life and mental health in patients after coronavirus disease 2019. It is also known as COVID-19 in brief. We know that COVID-19 is one of the most significant challenges for the human health today. This disease is highly contagious and lead to damage of different systems and organs in the human body. Recent COVID-19 studies have shown the interconnection of mental health problems with the quality of life recovery. And what is more, we know that patients after COVID-19 are used to experience symptoms of depression, anxiety, post-traumatic stress disorder, and other mental health disturbances that negatively associated with life quality. So we understand the necessity of investigation of quality of life of these type of patients, because we know that quality of life is a complex characteristic of values, perspectives, functionality, spirituality, attitudes, life satisfaction, taken with the cultural context of human life. Quality of life is often used as endpoints of different medical researches because it promotes evaluation of symptomatic care results and recovery of patients. Therefore, the aim of our study was to investigate mental health and the quality of life 3 months after discharge from the hospital in patients diagnosed with COVID-19 pneumonia. This study is a part of 1-year cardiac follow-up of COVID-19 pneumonia. It is big research of our research center. Specialists of different medical directions took part in this research. And in this study, I included data from cardiologists, neurologists, psychiatrists, and me, clinical psychologists that I collected. All patients included in this research were enrolled 3 months after discharge. Cardiologist examined cardiovascular health, neurologist, I'm sorry for word loss. Neurologist had examined cognitive functioning with MOCA test. Psychiatrist used structural interview for exploration of mental health status, and at my medical appointments, patients filled a form that consisted of scales that you can see on the screen. HADS for anxiety and depression symptoms, GAD-7 for anxiety symptoms, PHQ-9 for depression symptoms, PSS-10 for estimation of perceived stress, and the quality of life was assessed by SF-36. We use this questionnaire often because it allows to understand quality of life fully. Results are presented in 10 subscales. 8 subscales describe different domains of life quality, and 2 subscales present generalized indices of mental and physical health. And it is necessary to notice that results of SF-36 can't be categorized. We can understand it only comparing with something. And also we use the discharge summaries of our patients for understanding the severity of pneumonia caused by COVID. So let's move on results. You can see that cardiovascular disorders were presented in almost 80% of patients. The most common cardiovascular disorders are hypertension and chronic heart failure. Also, there were coronary artery disease and rhythm and conduction disturbances. As for pneumonia severity, half of our patients had moderate and severe lung injury. Duration of hospitalization, median mean was 13 days. Duration of stay in intensive care unit was 8 days. And intensive care unit stay was needed to 10% of our patients. The prevalence of disorders in psycho-emotional sphere is common in almost half of patients. You can see that anxiety and depression symptoms are presented at 1/3 of patients, and stress symptoms have less than 10% of our patients. As a result of comparing psycho-emotional disorders by gender, we found out that women are used to feel it more frequent than men in 2.5 times. In 2.5 times, it belongs to symptoms of stress and depression, but symptoms of anxiety are common in women in 3 times. It corresponds to other studies and confirms women understand their emotional state better than men do. Quality of life is better generally in men compared with women. You can see that results of all SF36 subscales are higher in men. We suppose that women, despite their health status, are busier with job and family, and hormonal instability can contribute to it. However, we should pay attention to the subscale bodily pain. Here it is marked with a red circle. This subscale has reverse meaning. That's why we get known that male responders are used to feel pain sensation more intensive than women do. How can we understand it? I think that there are some physiological differences in men and women. For example, greater tolerance to pain in women. Also, we found some differences in life quality in patient groups by employment and marital status. You can see that there were unemployed 1/3 of our patients, and among those patients who were unemployed, physical health component was has lower rates compared with employed ones. However, employed patients are used to feel greater pain sensations than unemployed do. So, to understand, physical health component is better in employed patients, but unemployed patients feel less pain sensations. It can be understood with job with the job busyness as a coping mechanism. When a person is busy with something, he has no time to feel himself bad. But busyness also has another side. Taking in attention that these patients are after COVID, they are feeling asthenic and other conditions. That's why bodily pain in this group is higher. And a little bit more than 1/4 of our patients were unmarried. This group of responders have higher rates in social functioning. It was surprising for us that married patients are worse in social functioning, because we used to think that that family should support should be a support in social way. But yesterday I've got some answers to this question in section of clinical psychology. It was, I get known that hostility is often seen in patients after COVID-19. And we should know that these patients were, got home and used to be isolated from 2 weeks to 1 month. They were isolated with their spouses or their family, and there can be actual family burden, because as they feel themselves not healthy, their relatives should take care of them. So let's go further. Physical aspect of life quality was associated with age, cardiovascular comorbidity, and duration of stay in intensive care unit. Multifactorial analysis showed that physical health, it is a generalized subscale of SF-36, was affected by age only. Mental health or psychological aspect of life quality is associated with levels of stress, depression, and anxiety. You can see that problems of psycho-emotional sphere negatively correlate with mental health in all domains of SF-36. And the multifactorial analysis showed us that main problems in mental health were caused by presence of stress and levels of depression. Psychopathological symptoms were identified in almost 90% of responders. Medication was prescribed to 17%. Medication primarily included anxiolytics and antidepressants. The most common psychopathological symptoms were asthenia, anxiety, and adaptation disorders. In both men and women, psychopathological comorbidity correlated with the quantity of psychotropic medication. In female, but also we found some gender differences. In female respondents, high stress rates were associated with a decrease in social functioning. Probably it is related to social overload in women. And presence of psychopathological symptoms was negatively associated with vitality and general health. It reflects subjective worsening in physical health under the mental problems. In male responders, bodily pain was more intensive, while their mental health was better. In addition, physical functioning became worse under the growth of cardiovascular pathology. That's why we suppose that physical health is of great importance in men. It is interesting, yes, get back. It is interesting that there were more patients with diagnosed psychopathological problems identified by the psychiatrist than by full field scales. It is possible to assume that the specialist is more accurate in diagnostics than screening scales on one hand, and some patients don't realize their condition in cause of psychological defense mechanisms on another. Here is data from neurologists. We got known that 1/4 of our patients got cognitive decline by a MOCA test. Okay.
Half of it.
Okay, and subjective cognitive decline was common. Subjective cognitive decline was found out more frequent than objective. Patients with objective cognitive decline were elder, and objective cognitive decline was associated with the symptoms of depression, stress, and bodily pain indices. So the conclusions of our study are the following. Physical aspect of life quality depends on severity of cardiovascular pathology and quantity of cardiovascular disease, also on severity of pneumonia, and it decreases in relation to age. Psychological aspects of life quality depends on severity of psycho-emotional sphere disorders, depends on presence of perceived stress, and depression. According to gender, women are used to feel psycho-emotional disorders higher 2.5 times. Physical health is more important for male gender. Marital status, unmarried patients are more active and socially, and patients with decreased cognitive functioning feel less pain sensations, but more stress and depression symptoms. And some words about applying our results in real practice. You can see here on the screen. So first part, it is stress-reducing psychotherapy or psychological correction, then preservation of family and close relationships, and symptomatic psychotherapy of asthenia, anxiety, depression, cognitive decline, and other symptomatic problems. Thank you for your attention.
Thank you.
So we have time just for one question. Do we have questions?
Yeah, thank you for your presentation. You've done a tremendous job. Maybe it was to my inattentiveness, but I don't get, maybe it was on slide 5. There were columns for depression, anxiety, stress, and psycho-emotional disturbances. Could you please clarify? Yeah, psycho-emotional disorders. Could you please clarify what stands for that exactly?
Psycho-emotional disorders here included all symptoms by scales, by GAD-7, PHQ-9,
okay.
and PSS-10. And here you can see it separately.
Thank you.
Thank you very much.
Thank you.
Thank you.
We are running out of time, but we need to stay online and in attention for a few minutes. And I would like to give the floor to Olga Karpenko, who will introduce some opportunities for early career researchers in regarding the publishing, and she will present a special issue and call for papers in special issue.
Thank you very much. Because I noticed that the language here is English, I will speak English. Actually, I was very happy to be here and to listen the speech of early career psychiatrists, and I must say that your English is perfect. And so I think that maybe the information I will give to you will be interesting, because we have the same idea that because the language of science is English, so we started to publish a scientific journal. Maybe you paid attention that we have an exhibition with distributed journal during the conference, and maybe some of you bought issues of this journal because we distributed them here. And so this is our website. We already issued 6 issues, so then one will be 8 in June, and next will be in September, and we want to make it a special issue for early career psychiatrists. So here you can see the call for papers. On our website you will find guidelines for authors. We tried to comply with international publishing guidelines and ethics, so you will find quite precise instruction there, what the research paper should be, how it should be structured, what are the requirements for reviews, and also we will have a competition, and we have a money prize of 500 euros or 50,000 rubles for the best paper. So also it might be not only pleasant for you, but also useful in terms of from economical point of view. And I must say, disclose that still we are not indexed in database. databases. So we are indexed in Doage, in Google Scholar, also in Linz, but the journal is open access, no charge from authors. You can send papers in Russian and in English, but I hope that you will send them directly in English, because I noticed that no problems with English. And then they go the process of peer review, and maybe it also will be good for you in terms of improving your scientific writing, because our peer reviewers are renowned international authors, so they can give you valuable feedback. Also, we have an editor who is in England, so she also complies with all these publishing rules and good standards. So it also may be useful in terms of improving writing skills. And also the journal is distributed to psychiatric associations, to the editorial boards, to authors, so we try to promote it. So maybe it will not improve from the point of view of indexing, but in terms of citations, in terms of getting more writing skills and getting promoted, this will be a good opportunity, and also a chance for, if your paper will be considered the best one, to get small amount of money for your research activities.
Thank you.
Thank you. Thank you.
Very important information, because we have also the thing that we have guest editors, and here 2 guest editors are present in the presidium, Sergei Potanin and Igor Chumakov. And maybe if this experience will be good for us, we can continue these things with guest editors. We in old age psychiatry issue, we had a guest editor, young psychiatrist from India.
Thank you. Thank you.
Giving me an opportunity to speak.
Yes, I should also tell that in Bechtereva National Medical Research Center, we also have 2 journals, one in Russian, other in English, and we welcome each of you to publish in our journals also. And you can write to Young Scientist Council if you need some help in editing your manuscript, and welcome. Welcome. And we running out of our time, but we have the last but not least speaker, Igor Chumakov, and his report about bipolar disorder type 2, diagnostic and differential diagnostic issues.
Thank you for those who are still in the audience and online. I will try to do my best to reduce the number of minutes of my presentation, and also minimize influence on your ability to have a break for coffee and for some meal. When I applied for this presentation, I supposed that we will have our own results of a PhD study of psychiatrists in my department, but unfortunately the study is not finished, and that's why I can't present these results, and I will have only theoretical ideas, but I want to use this chance to speak about classifications, about ICD-11, about the shift of paradigm, and about the changes in our clinical practice, and to comment, if I could say like this, reports that were presented during yesterday's plenum and yesterday plenary sessions about different points of view on ICD-11, about its clinical utility, and about how it could be transferred in our clinical practice with or without changes. And I think that yesterday there were experts talking about their experience and their work on translation of the classification and also about adaptation of the translation to Russian reality. And I can comment from the experience of early career psychiatrist and from experience from a lot of colleagues with whom I'm speaking and with whom I have studied, with whom I'm communicating and asking their point of view about the new classification, and also not only from Russia, but also in international perspectives. And I can say that there are more positive way of thinking about new classifications, because each new classification is some sort of consortium, and people who professionals who participated in making these classifications were part of a global international community. And I think that very important point, if our society and our professionals in Russia are not fully agree with some kind of criteria or some kinds of disorders or some changes, I think it is important to increase our own influence on these decisions and these decisions which were being made, and increase our involvement in international associations and in the work of international working groups. And I think, I'm very happy that some early career psychiatrists who are participating in this particular symposium are members of several working groups, international, and several task forces. And I think this is a nice step to start this global process and to continue this global process of involvement, our opinions and our points of view in international perspectives. And I think that this will improve understanding how bright, how kind, and how clever our researchers are, and that we are part of international research community. Regarding my presentation, my topic was dedicated to bipolar disorder type 2, and this is a nice example of how new ways of diagnosing mental disorders come to clinical practice, because bipolar disorder type 2 is some sort of new diagnostic category in ICD-11. We already have this diagnostic category in ICD-10, but it was specified in other bipolar disorders. But now we will have a separate diagnostic category, and I think that it is very important because according to clinical guidelines and clinical guidelines which were prepared by the Russian Society of Psychiatrists, they have extremely different types of treatment lines in bipolar disorder type 1 and bipolar disorder type 2. And I think that my presentation could also show how the research provided in regard of identifying key issues predicting bipolarity in unipolar depression could influence the decision being made on the updating the current guidelines. I will not stop on the definition of bipolar disorder. I just want to highlight once again difference between bipolar disorder type 1 and bipolar disorder type 2 according to ICD-11, and that one important thing which was highlighted also yesterday by Professor Masalov during plenum session, that hypomanic episode without history of other types of affective episodes would not be considered as a diagnosis of affective disorder according to ICD-11. And I also agree that this is controversial point of view, and we need to think how this will influence our clinical reality. But on the other hand, I really don't believe that a person who will have the first hypomanic episode will come to see a psychiatrist and will ask for treatment. That is why I think it will not influence at all our clinical practice, and it is. So I don't believe that we will have a lot of clinical cases when we will deal with this new exclusion criteria. As you see in ICD-11, we will have a separate diagnosis of bipolar type 1 disorder, bipolar type 2 disorder, and these disorders would be in a group of bipolar or related disorders, because cyclotimic disorder will be part of this special group, bipolar or related disorders. And we have already data about inter-rater reliability of ICD-11 diagnosis. Unfortunately, we have data only about bipolar type 1 disorder, but this data is also this inter-rater reliability has very strong support for using this diagnostic criteria. I think it is very important also to show for the researchers who provide this study also about diagnostic reliability of bipolar type 2 disorder, because there are a lot of questions regarding how can we not believe but rely on a history of hypomanic episodes from patient's memory perspective, because in some periods, affective state could influence how people could assess their history and how they could give their own personal view on the severity of symptoms. But this is a question for a long discussion and separate presentation. I will skip some slides. What is important, referring to Evgeny Kasyanov's presentation today, is that when we speak about bipolar disorder, patients with bipolar disorder spend the most long time in depressive states, but not in mania or hypomania states. But it is very important. That is why it is very important to make a differential diagnosis for patients when we see them in depressive state and we don't know medical history of hypomania or mania episodes in this patient. And regarding the diagnostic criteria of hypomanic episodes in ICD-11, they were updated, and there is a new criteria both for mania and hypomania, with increased activity or subjective experience of increased energy. And also a new feature is that we don't have now special number of days after which we could diagnostic hypomanic episode. It's just mention of several days, and I also think that it's important to our society to have some comments to clinical practitioners and recommendations how to manage this recommendation, like several days, and what is several, 2 is it several, or 4 is several, or just 3 days is several days. And I think it is important to give some official recommendations how to use this classification. And also, I wanted to present two big studies which came which influenced the decision of updating the classification. And one study was published in 2011. It was a big multicultural study with 18 countries regarding the signs of bipolarity in patients with major depression. And the main outcomes were that history of 2 or more affective episodes, hypomania, mania in first-degree relatives, current mixed condition, and mania-hypomania induced by antidepressants are strong signs of bipolarity in patients with major depressive disorder. And another more previous study by Mario Mai showed that drug-induced hypomania had 100 specificity as a sign of bipolarity in patients with monopolar depression, along with other types of symptoms. And this leads to a new update in ICD-11 regarding the diagnosis of bipolar disorder, that manic and hypomanic syndrome arising during antidepressant treatment should be considered as a manic episode if the syndrome persists after the treatment is discontinued and the full diagnostic treatments of manic or hypomanic episode are made after the direct physiological effects of the treatment are likely to have receded. This is a good example how international studies influence the decision we made on updating the classifications. And I would like to finish with two tables about necessity of providing differential diagnosis in patients with bipolar disorder, because we have a lot of symptoms which are common in different diagnostic categories, and that is why it is very difficult sometimes to make an accurate diagnosis, especially with anxiety or anxiety-related disorders, and especially with borderline personality disorder. And in conclusion, I want to draw your attention to clinical guidelines which are published, and you have direct access from Russian Society of Psychiatrists webpage to these clinical guidelines, and you can find there more information about diagnosis, differential diagnosis, and treatment guidelines in patients both with bipolar disorder first type and second types. Thank you for your attention.
Thank you, Igor. One question.
Where is the mute?
One question. Do you think there are patients with bipolar II disorder who can receive only antidepressants and monotherapy?
I think that decision on therapy should be personalized. I think that there is a small amount of patients who will benefit from monotherapy of antidepressants, but this decision should be based on evidence that other sorts of therapy are not effective. For example, if a patient had very strong side effects on other types of evidence-based therapy, and for example, had serious, severe depressions and only a history of a short one-time period of hypomania, and in this case, we need to decide what is better for this particular person. To continue having drugs, for continue prescribing drugs with these strong side effects, or try another theory and try to use monotherapy of antidepressant and see if it really should, if it really could improve the state without any consequences regarding the switching to hypermoney and money. But this will be a very difficult decision.
Okay, thank you.
Thank you.
We thank all our wonderful audience. We thank our fabulous speakers. The first part of our symposium is over. And we hope that we'll see all of us on the second part. We'll start it a little bit later at 10
15 minutes, maybe.
Yeah.
To give you time to have a break.
Yes. And I'd like to tell that for all our guests from Omsk, from Tomsk, from Moscow, we have such wonderful presents, our university calendars. So, thank you. And that's all.
Yeah, that's all. See you.
See you later.
Мы Янсен. Каждое утро мы просыпаемся для того, чтобы сделать возможным то, что еще вчера казалось невероятным. Мы прокладываем путь туда, куда другие боятся смотреть. Изучаем и воссоздаем сам код жизни, чтобы лечить, помогать, исцелять. Мы открываем двери для сотрудничества, а умы и сердца для пациентов, чтобы наши успехи в лабораториях спасали жизни. Мы создаем инновации в лекарственной терапии и делаем их доступными для всего мира. Мы Янсен, фармацевтические компании Джонсон & Джонсон. Это наша жизнь и мечта, в которую мы верим. Мы будем использовать науку для борьбы с заболеваниями, изобретать, как помочь тем, кто нуждается в помощи, исцелять безнадежность человеческим теплом до тех пор, пока самые тяжелые заболевания не останутся лишь на страницах истории. Янсен. Создаем будущее, где заболевания останутся в прошлом.
Более 60 лет фармацевтическая компания Janssen разрабатывает новые лекарственные препараты, меняя жизнь пациентов с шизофренией к лучшему. Основатель фармацевтической компании Пол Янсен, исследователь, разработчик лекарственных препаратов, 8 раз был номинирован на Нобелевскую премию в области медицины. В 1959 году Пол Янсен синтезировал галоперидол, который до сих пор является золотым стандартом в лечении шизофрении. В дальнейшем была создана молекула рисперидона. В 2007 году разработан палиперидон, одна из самых современных молекул на сегодняшний день. Палиперидон является антагонистом серотониновых и дофаминовых рецепторов и оказывает мощный эффект в отношении позитивной и негативной симптоматики. При этом он не блокирует другие типы рецепторов, что обеспечивает хорошую переносимость и отсутствие седации. С 2021 года компания Janssen предлагает стратегический подход к лечению шизофрении. Тривиктоплан – это 3 контролируемых терапевтических шага на пути к ремиссии, социализации и улучшению качества жизни. От ежедневного приема таблетированных препаратов к Тривикте, препарату с режимом дозирования 4 раза в год. Тривиктоплан обеспечивает безопасность, уверенность в переносимости в рамках одной молекулы палиперидона, стабильность и длительную ремиссию, и удобство за счет перехода к комфортному для пациентов формату лечения. Сегодня Янсен продолжает заботиться о пациентах с шизофренией и ставит своей целью достижение стойкой ремиссии и возвращение пациента в семью, в привычный круг общения и к самостоятельной трудовой деятельности.
Шизофрения – это тяжелое хроническое психическое заболевание, которое характеризуется выраженными негативными последствиями для здоровья пациента, а также для общества и экономики. Антипсихотики, применявшиеся до настоящего времени, позволяли эффективно уменьшать выраженность в большей степени позитивных симптомов шизофрении, однако могли практически не влиять на негативные и когнитивные симптомы. Благодаря механизму действия и уникальному профилю рецепторной активности, карипразин обеспечивает новые возможности в лечении пациентов с негативными симптомами шизофрении. Карипразин входит в подгруппу атипичных антипсихотиков, которые являются частичными агонистами дофаминовых D2 и D3 рецепторов. Обладая парциальной агонистической активностью, карипразин действует как агонист при низком уровне эндогенного дофамина или как антагонист при высоком уровне эндогенного дофамина. Распределение дофаминовых D2 и D3 рецепторов в головном мозге различно. Рецепторы подтипа D3 экспрессируются в основном в тех отделах мозга, которые связаны как с аффективной, так и с когнитивной симптоматикой при шизофрении. Ученые компании Гидеон Рихтер стремились найти молекулу, которая бы обладала высоким сродством как к D3, так и к D2 дофаминовым рецепторам, но с преимущественным связыванием с D3. Карипразин обладает уникальной особенностью высокого субнаномолярного и преимущественного сродства к дофаминовым D3 рецепторам. Этот эффект наблюдался не только в доклинических испытаниях, но и в клинических исследованиях у человека. В настоящее время карипразин является единственным нейролептиком с преимущественным сродством к дофаминовым D3 рецепторам. Карипразин также обладает низким и умеренным сродством к множеству других рецепторов, например, к гистаминовым, альфа-адренергическим и мускариновым рецепторам, и профиль его безопасности является благоприятным. Свойства карипразина обусловлены его механизмами действия, например, непрямым влиянием на глутаминергическую систему, что может иметь важное значение. То, что карипразин является парциальным агонистом с преимущественным связыванием с D3 рецепторами, имеет особое значение в лечении шизофрении. Карипразин способен одновременно воздействовать на позитивные симптомы, обусловленные чрезмерной активацией дофаминергической системы, и уменьшать выраженность негативной и когнитивной симптоматики. Карипразин – это парциальный агонист D3 и D2 дофаминовых рецепторов с преимущественным связыванием с D3 рецепторами и клинически доказанной эффективностью у пациентов с позитивными и преобладающими негативными симптомами шизофрении.
Мы Янсен. Каждое утро мы просыпаемся для того, чтобы сделать возможным то, что еще вчера казалось невероятным. Мы прокладываем путь туда, куда другие боятся смотреть. Изучаем и воссоздаем сам код жизни, чтобы лечить, помогать, исцелять. Мы открываем двери для сотрудничества, а умы и сердца для пациентов, чтобы наши успехи в лабораториях спасали жизни. Мы создаем инновации в лекарственной терапии и делаем их доступными для всего мира. Мы Янсен, фармацевтические компании Johnson & Johnson. Это наша жизнь и мечта, в которую мы верим. Мы будем использовать науку для борьбы с заболеваниями, изобретать, как помочь тем, кто нуждается в помощи, исцелять безнадежность человеческим теплом до тех пор, пока самые тяжелые заболевания не останутся лишь на страницах истории. Янсен. Создаем будущее, где заболевания останутся в прошлом.
Более 60 лет фармацевтическая компания Janssen разрабатывает новые лекарственные препараты, меняя жизнь пациентов с шизофренией к лучшему. Основатель фармацевтической компании Пол Янсен, исследователь, разработчик лекарственных препаратов, 8 раз был номинирован на Нобелевскую премию в области медицины. В 1959 году Пол Янсен синтезировал галоперидол, который до сих пор является золотым стандартом в лечении шизофрении. В дальнейшем была создана молекула рисперидона. В 2007 году разработан палиперидон, одна из самых современных молекул на сегодняшний день. Палиперидон является антагонистом серотониновых и дофаминовых рецепторов и оказывает мощный эффект в отношении позитивной и негативной симптоматики. При этом он не блокирует другие типы рецепторов, что обеспечивает хорошую переносимость и отсутствие седации. С 2021 года компания Janssen предлагает стратегический подход к лечению шизофрении. Тривиктоплан – это 3 контролируемых терапевтических шага на пути к ремиссии, социализации и улучшению качества жизни. От ежедневного приема таблетированных препаратов к Тривикте, препарату с режимом дозирования 4 раза в год. Тривиктоплан обеспечивает безопасность, уверенность в переносимости в рамках одной молекулы палиперидона, стабильность и длительную ремиссию, и удобство за счет перехода к комфортному для пациентов формату лечения. Сегодня Янсен продолжает заботиться о пациентах с шизофренией и ставит своей целью достижение стойкой ремиссии и возвращение пациента в семью, в привычный круг общения и к самостоятельной трудовой деятельности.
Шизофрения – это тяжелое хроническое психическое заболевание, которое характеризуется выраженными негативными последствиями для здоровья пациента, а также для общества и экономики. Антипсихотики, применявшиеся до настоящего времени, позволяли эффективно уменьшать выраженность в большей степени позитивных симптомов шизофрении, однако могли практически не влиять на негативные и когнитивные симптомы. Благодаря механизму действия и уникальному профилю рецепторной активности, карипразин обеспечивает новые возможности в лечении пациентов с негативными симптомами шизофрении. Карипразин входит в подгруппу атипичных антипсихотиков, которые являются частичными агонистами дофаминовых D2 и D3 рецепторов. Обладая парциальной агонистической активностью, карипразин действует как агонист при низком уровне эндогенного дофамина или как антагонист при высоком уровне эндогенного дофамина. Распределение дофаминовых D2 и D3 рецепторов в головном мозге различно. Рецепторы подтипа D3 экспрессируются в основном в тех отделах мозга, которые связаны как с аффективной, так и с когнитивной симптоматикой при шизофрении. Ученые компании Гидеон Рихтер стремились найти молекулу, которая бы обладала высоким сродством как к D3, так и к D2 дофаминовым рецепторам, но с преимущественным связыванием с D3. Карипразин обладает уникальной особенностью высокого субнаномолярного и преимущественного сродства к дофаминовым D3 рецепторам. Этот эффект наблюдался не только в доклинических испытаниях, но и в клинических исследованиях у человека. В настоящее время карипразин является единственным нейролептиком с преимущественным сродством к дофаминовым D3 рецепторам. Карипразин также обладает низким и умеренным сродством к множеству других рецепторов, например, к гистаминовым, альфа-адренергическим и мускариновым рецепторам, и профиль его безопасности является благоприятным. Свойства карипразина обусловлены его механизмами действия, например, непрямым влиянием на глутаминергическую систему, что может иметь важное значение. То, что карипразин является парциальным агонистом с преимущественным связыванием с D3 рецепторами, имеет особое значение в лечении шизофрении. Карипразин способен одновременно воздействовать на позитивные симптомы, обусловленные чрезмерной активацией дофаминергической системы, и уменьшать выраженность негативной и когнитивной симптоматики. Карипразин – это парциальный агонист D3 и D2 дофаминовых рецепторов с преимущественным связыванием с D3 рецепторами и клинически доказанной эффективностью у пациентов с позитивными и преобладающими негативными симптомами шизофрении.
Мы Янсен. Каждое утро мы просыпаемся для того, чтобы сделать возможным то, что еще вчера казалось невероятным. Мы прокладываем путь туда, куда другие боятся смотреть. Изучаем и воссоздаем сам код жизни, чтобы лечить, помогать, исцелять. Мы открываем двери для сотрудничества, а умы и сердца для пациентов, чтобы наши успехи в лабораториях спасали жизни. Мы создаем инновации в лекарственной терапии и делаем их доступными для всего мира. Мы Янсен, фармацевтические компании Johnson & Johnson. Это наша жизнь и мечта, в которую мы верим. Мы будем использовать науку для борьбы с заболеваниями, изобретать, как помочь тем, кто нуждается в помощи, исцелять безнадежность человеческим теплом до тех пор, пока самые тяжелые заболевания не останутся лишь на страницах истории. Янсен. Создаем будущее, где заболевания останутся в прошлом.
Более 60 лет фармацевтическая компания Janssen разрабатывает новые лекарственные препараты, меняя жизнь пациентов с шизофренией к лучшему. Основатель фармацевтической компании Пол Янсен, исследователь, разработчик лекарственных препаратов, 8 раз был номинирован на Нобелевскую премию в области медицины. В 1959 году Пол Янсен синтезировал галоперидол, который до сих пор является золотым стандартом в лечении шизофрении. В дальнейшем была создана молекула рисперидона. В 2007 году разработан палиперидон, одна из самых современных молекул на сегодняшний день. Палиперидон является антагонистом серотониновых и дофаминовых рецепторов и оказывает мощный эффект в отношении позитивной и негативной симптоматики. При этом он не блокирует другие типы рецепторов, что обеспечивает хорошую переносимость и отсутствие седации. С 2021 года компания Janssen предлагает стратегический подход к лечению шизофрении. Тривиктоплан – это 3 контролируемых терапевтических шага на пути к ремиссии, социализации и улучшению качества жизни. От ежедневного приема таблетированных препаратов к Тривикте, препарату с режимом дозирования 4 раза в год. Тривиктоплан обеспечивает безопасность, уверенность в переносимости в рамках одной молекулы палиперидона, стабильность и длительную ремиссию, и удобство за счет перехода к комфортному для пациентов формату лечения. Сегодня Янсен продолжает заботиться о пациентах с шизофренией и ставит своей целью достижение стойкой ремиссии и возвращение пациента в семью, в привычный круг общения и к самостоятельной трудовой деятельности.
Шизофрения – это тяжелое хроническое психическое заболевание, которое характеризуется выраженными негативными последствиями для здоровья пациента, а также для общества и экономики. Антипсихотики, применявшиеся до настоящего времени, позволяли эффективно уменьшать выраженность в большей степени позитивных симптомов шизофрении, однако могли практически не влиять на негативные и когнитивные симптомы. Благодаря механизму действия и уникальному профилю рецепторной активности, карипразин обеспечивает новые возможности в лечении пациентов с негативными симптомами шизофрении. Карипразин входит в подгруппу атипичных антипсихотиков, которые являются частичными агонистами дофаминовых D2 и D3 рецепторов. Обладая парциальной агонистической активностью, карипразин действует как агонист при низком уровне эндогенного дофамина или как антагонист при высоком уровне эндогенного дофамина. Распределение дофаминовых D2 и D3 рецепторов в головном мозге различно. Рецепторы подтипа D3 экспрессируются в основном в тех отделах мозга, которые связаны как с аффективной, так и с когнитивной симптоматикой при шизофрении. Ученые компании Гидеон Рихтер стремились найти молекулу, которая бы обладала высоким сродством как к D3, так и к D2 дофаминовым рецепторам, но с преимущественным связыванием с D3. Карипразин обладает уникальной особенностью высокого субнаномолярного и преимущественного сродства к дофаминовым D3 рецепторам. Этот эффект наблюдался не только в доклинических испытаниях, но и в клинических исследованиях у человека. В настоящее время карипразин является единственным нейролептиком с преимущественным сродством к дофаминовым D3 рецепторам. Карипразин также обладает низким и умеренным сродством к множеству других рецепторов, например, к гистаминовым, альфа-адренергическим и мускариновым рецепторам, и профиль его безопасности является благоприятным. Свойства карипразина обусловлены его механизмами действия, например, непрямым влиянием на глутаминергическую систему, что может иметь важное значение. То, что карипразин является парциальным агонистом с преимущественным связыванием с D3 рецепторами, имеет особое значение в лечении шизофрении. Карипразин способен одновременно воздействовать на позитивные симптомы, обусловленные чрезмерной активацией дофаминергической системы, и уменьшать выраженность негативной и когнитивной симптоматики. Карипразин – это парциальный агонист D3 и D2 дофаминовых рецепторов с преимущественным связыванием с D3 рецепторами и клинически доказанной эффективностью у пациентов с позитивными и преобладающими негативными симптомами шизофрении.
Что, можем начинать, нет? Еще нет?
Ой, моя сумка лучше, наверное, вниз, Сергей Сергеевич. На пол трудно.
На пол?
Прям в камеру попадает, да. Так, почта.
Okay, dear colleagues, we are finally ready to start, to continue our session. I'm glad to present next speaker. Екатерина Игоревна Пальчикова, junior researcher of gerontological department of National Medical Research Center of Psychiatry and Neurology, Bechtereva. So the presentation will be about late onset schizophrenia as a neurobiological syndrome.
Thank you. Hello, colleagues. Hello again. I hope everyone is fed and feels comfortable. Let's continue our symposia, and I want to tell you about late onset schizophrenia. If we talk about the relevance of the theme, we should understand that. First of all, I want to say that late onset schizophrenia is not that rare as it may seem. You can see that about 24% of schizophrenia debuts occur at the age of 40 and more. About psychotic disorders of late life are associated with higher mortality and higher frequency of side effects from antipsychotics. However, we don't have enough data about good treatment practice of this condition, and randomized controlled trials results are only extrapolated to late onset schizophrenia from studies with younger samples. What we know. Schizophrenia was originally conceptualized by Kraepelin in 1896 as a progressive deteriorating condition. First neurovisualization data confirmed this statement. But there are subtle brain changes at first onset. For example, abnormal purification, decreased cortical and hippocampal volume. Later, they find that there is an excess of CNVs, prenatal features, neonatal signs, for example, motor and language, and no gliosis post-mortem. Apoptosis is not gliosis. So, patients with schizophrenia more often met the neurodevelopment hypothesis of psychosis. About schizophrenia at all. The first definition of schizophrenia was given by Kraepelin, and he said that it's a disease that begins at early age, the progressive course and outcome and dementia is of a special type. Next, Eugen Bleuler said that the main symptoms of schizophrenia is disorders of associative synthesis, autism, apathy, ambivalence. Next, the son of Eugen Bleuler, Manfred Bleuler, said that late schizophrenia exists. And later, schizophrenia is considered late as the age of 40, and it meets more common in women and has a lower risk of inheritance. As the age increases, the influence of the genetic factors of the development of psychosis is less pronounced than at the young age. Environmental, epigenetic factors and the neurodegeneration play a leading role in the development of late-onset psychosis, which indicates the possible presence of the common mechanisms for the development of all of them. You can see in that slide clinical differences of late-onset schizophrenia. For example, delusion is more often had paranoid ideas with a small range. Patients more often tell about the feeling of someone presence, like hallucination or delusion plot also. The feeling of passing through walls. Hallucination always multimodal, for example, verbal and visual both. Negative symptoms means rare. Thought process disorders also rare. Markers and possible mechanisms of pathogenesis of latent-onset schizophrenia divide into three types. For example, neuroinflammation, classical theory that said that a lot of cytokines, inflammation markers increased. For example, there is a study of, I think, 2014, when it was said that increased C-reactive protein is associated with a 6 to 10-fold increase in the risk of the development late and very late schizophrenia after a few years. About neuroimaging, we know that hyperintensivity of white matter in the temporoparietal, frontal, occipital areas, thalamus, and paraventricular areas were detected. However, the picture is similar to that in healthy subtypes group. About proteostasis imbalance, we know that in latent-onset schizophrenia, limbic tauopathy, atrophy of the white matter plays a role. If we talk about proteostasis imbalance as a main theory of late-onset schizophrenia, we can say that post-mortem studies revealed a hyperphosphorylation of tau protein. Apolipoprotein E4 allele is predictor of psychosis at late age, and it was not associated in young people with schizophrenia. We know that mutation of chemokine receptor type 5 associated with latent-onset schizophrenia, and it's found that in patients with early debut of neurodegenerative diseases. Also, polymorphisms of D2 receptor is associated with late-onset schizophrenia. All these points to pathogenetic differences between schizophrenia and latent-onset schizophrenia and the greater contribution of the neurodegeneration to the development of the latter. If we talk about imbalance of proteostasis, I want to stop near synaptopathies because we know that overexpression of alpha-synuclein mRNA and abnormal aggregation of proteins is the main pathogenetic mechanisms of synucleinopathies, and one of the links of the pathogenesis of Alzheimer's disease. Also, alpha-synuclein is able to influence the intracellular content of dopamine by direct interaction with proteins that regulate its reverse synthesis and capture. So, the change in dopamine levels in the midbrain largely determines the clinic of both diseases with Lewy bodies and schizophrenia. I mean, the diseases with Lewy bodies, Parkinson's disease, and dementia with Lewy bodies. About our study, hypothesis of the study was that clinical manifestations of late-onset schizophrenia may be associated with overexpressions and change in alpha-synuclein levels. In the loss group, patients met the criteria for paranoid schizophrenia by ICD-10 with a debut older than 40 years and without dementia syndrome. The control group had no mental or neurological disorders. All groups were comparable in gender and age. Laboratory part included determination of CNSA mRNA on the surface of lymphocytes, alpha-synucleins in lymphotic fraction. Latent-onset schizophrenia group also underwent psychopathological examination, including clinical interview skills, PANS, MOCA, BACS, etc. There was 55% women in the studies. The average age of the onset of latent-onset schizophrenia was 49 years. The average prescription from the onset of the disease was 11 years. 54% in the late-onset schizophrenia group had a diagnosis of organic brain disorder. About 30% has paranoid schizophrenia, and 16% has delusional disorders. And you remember that all the patients underwent criteria by ICD-10 as paranoid schizophrenia. It's about clearance of diagnosis in our country. Also about scales. I'll present here only MOCA test and PANS because some part of my study is in process now. And if we talk about MOCA, we can see that all of the participants had presence of cognitive decline, but they had no dementia. And cognitive decline negatively correlated with age. About PANS scale, average score of the scale of positive symptoms was 23, negative symptoms 80, general psychopathological symptoms 17. It was negative correlation with age also. And about synuclein. The mRNA level of the CNCA gene was higher in the lost group. You can see that the differences is significant. Also, the alpha-synuclein level was higher in patients with left-onset schizophrenia compared to controls. In conclusion, I want to say that taking into account of the statements, we can conclude that late-onset schizophrenia is more often diagnosed as organic mental disorder and less often as schizophrenia. The severity of positive, negative, and general psychopathological symptoms is low compared to primary psychotic disorders, which may indeed indicate other pathogenetic mechanisms of late-onset schizophrenia. Also, there is evidence that alpha-synuclein is able to influence the intracellular content of dopamine by direct interaction with proteins that regulate its reverse synthesis and uptake, as well as cause synaptic dysfunction. It's a novel data. The neurobiological aspect of latent-onset schizophrenia remain unexplored, but detected increase in the level of alpha-synuclein in mRNA CNCA gene probably suggests previously unknown mechanisms of pathogenesis of latent-onset schizophrenia, defining it as a neurodegenerative disease or even synucleinopathy, which requires further study. Thank you very much. Do you have any questions?
Thank you. Please ask your questions.
Okay.
Thank you for your presentation, great results. And I have a question about definition of late-onset schizophrenia.
Yeah.
Why did you use 40 years for point for specification?
Because it's literature data in classic literature and modern studies, latent-onset schizophrenia is always detected as when debut of the psychosis is over 40 years, and plus ICD-10 criteria. So yes.
Ah, okay. Nice. In more disorders, we don't have
in ICD-10, we also have only paranoid schizophrenia, and that's all. But we see in our practice distinct, we see differences between paranoid schizophrenia debuted in the early age and latent-onset schizophrenia. Yeah, especially cognitive functions, yes, and maybe it's a prodrome of neurodegenerative diseases, because we know that latent-onset psychosis, which debuts over 60 years old, they give dementia, I think I can say about 25% in next 2 years. It's a big percentage. So I think we should study more this phenomenon, because therapeutic tactics need more studied also, because old people react to psychotics bad often, and we should take into account there is in other diseases and disorders. So there's a lot of issues.
Did you evaluate extrapyramidal side effects?
Yeah, actually in my study there is a UQ scale also, there is BAG scale also. I presented only part of it. Of course, I studied this phenomena also too, but I think that extrapyramidal symptoms more often meets in the patients of late group, of course, because they have, I think, organic stigmas. So it's a fact that, for example, patients with Lewy body dementia reacts very bad on the antipsychotics. So we can use only quetiapine, for example. Yeah. So I think on late onset schizophrenia, it's about the same, because we use the typical antipsychotics and they always react very bad.
Great, thank you.
Thank you.
Any other questions? Maybe online? No?
No.
What about limitations?
Evgeny Dmitrievich, I'm not ready for this question. I think I have limitation, of course, but we have limitation on time also.
Okay.
Maybe I'll tell you later.
Thank you.
Thank you.
So we can move to our next presentation. It's Mariana Anatolievna Tumova, junior researcher of biological therapy of Psychiatric Patients Department of National Medical and Research Center of Psychiatry and Neurology, Bechtereva, of Russian government Department, Ministry of Health. Yes, right. So the presentation will be about the features of visual perception in patients with schizophrenia. Please.
Hello everyone. In my presentation, I will introduce to you the views on the features of visual system in patients with schizophrenia. This work was prepared in collaboration with my colleagues from the Bechtereva National Research Medical Center Psychiatry and Neurology, the Popov Institute of Physiology, and St. Petersburg State University. This work was supported by a grant from the Russian Science Foundation. The first point I want to start with is the question: why study visual impairments in schizophrenic patients? Firstly, as is known, the eye is our window to the brain. So central processes occurring in the brain are reflected in the operation of vision, and certainly schizophrenia is a disease of the brain. Secondly, we know the patients with schizophrenia have impaired computational processes in the brain. Computational processes in different parts of the brain occur according to general principles. By studying this impairment in the visual system, we can learn more about the working of the whole brain and perhaps the symptom development mechanism of schizophrenia. Thirdly, we study vision in schizophrenic patients because processes occurring in the visual system are available for quantification. And finally, there is a lot of evidence about sensory impairments in patients with schizophrenia. As noted in an article by Pamela Barter and al., much work in the cognitive neuroscience of schizophrenia has focused on attention, memory, and executive function. Less work has focused on perceptual processing. Indeed, during the National Institute of Mental Health matrix consensus process, perception was not identified as one of the core cognitive domains relevant to schizophrenia or its treatment. The omissions of assessment of perceptual function from the matrix battery means that a set of functions that are frequently disrupted in schizophrenia are not being routinely assessed in clinical trials. Correction of these omissions is one of the goals of Scientrix project. The importance of studying perceptual processes is also supported by the fact that the National Institute of Mental Health in the research domain criteria project with the cognitive system domain identifies construct perception with subconstruct visual perception or detail perception and others. Perception is a complex process involving several brain structures and higher-level cognitive processes. Today, I'm going to talk about the perception of visual illusions, optical illusions. The use of visual illusions methodology to understand perceptual organization is informative. This is especially true given that different visual illusions must certainly engage different neural and cognitive operation, although these mechanisms remain to be more preciously identified. It follows that the study of visual illusions and their perceptual organization in schizophrenia can lead us to a more detailed qualitative understanding of the nature of some impairments related to perception organization in schizophrenia. Although visual illusions alter our perception of visual reality, they demonstrate how the brain uses specific mechanisms that are highly adaptive, such as those that allow for perception constancies. For instance, we need size constancy to have relatively stable experience of perceived size on object whose image on the retina changes continuously with variation in distance. The Ponzo illusion is one illusion that is widely believed to rely on these mechanisms. These adaptive mechanisms, which govern our visual experience, ultimately form part of our perceptual organization, providing rules by which to structure the visual input we receive into understandable pattern. While people with schizophrenia typically show decreased performance in cognitive tasks, it is interesting to note a more accurate performance in perceptual judgment tasks using visual illusions compared to controls. We can therefore assume the existence of a specific processing abnormality in these patients rather than artifact of a generalized cognitive deficit or of low-level visual problems. For illusion perception, patients with schizophrenia have been found to be less susceptible to many illusions compared to healthy controls. Tofu et al. Describe, on the contrary, how subjects who demonstrate schizotypal features, as well as patients with subclinical level of psychotic symptoms, relate significant more than controls on their priors to disambiguate noisy sensory information in visual perceptual tasks. This suggested that subjects displaying mild to moderate level of psychosis may show a stronger reliance on their prior relatively relative to sensory evidence. This is consistent with the idea that patients with schizophrenia might have a deficit of perceptual inference or in the equation of expectation. I'm going to tell you about a pilot study. We did compare the power of Müller-Weyher and Ponzo illusions in schizophrenic patients and healthy controls. We chose these illusions because they are illusions of length estimation, and they are supposed to occur at different levels of sensory information processing. The Müller-Weyher illusion is considered a classical low-level illusion, while the Ponzo illusion is high-level illusion. This is a cross-sectional study that included 27 inpatients, male and female, aged from 18 to 40 years with paranoid schizophrenia in subacute and remission state. Patients with schizophrenia, depending on their response to treatment, were divided in two groups: patients with treatment resistance and non-resistance patients. The first group consists of healthy subjects who did not have any mental disorder during their life. All study participants were relational in their behavior and were able to learn the instruction for the test. Clinical symptoms were evaluated by an investigator clinician using the PANSS scale during an interview. During the psychophysiological test, stimuli were presented on LCD optical multi-touch monitor. The experiment consisted of two parts, 25 trials in each. In each part, same stimuli set was used. Firstly, 5 neutral stimuli were presented, then the stimuli eliciting the Müller-Weyher illusion were shown. Then the 5 neutral stimuli were presented again, then the stimuli elicited the classical Ponzo illusion were shown. And at the end, the 5 neutral stimuli were presented again. At each stage, 5 different waves of central shafts were used in random order. In the first part, the method of adjustment was used for verbal responses. In each trial, the upper shaft was the etalon and the subject had to change the length of the lower shaft by pressing the keys up or down. The task was to equalize the lengths of both central shafts. There was no time limit for the task. The subject pressed the enter key when he decided that the adjustment was done. In the second part, the tracing task was used the sensory motor responses. The instruction given to the participant was to move the hand across the shafts using the index finger, from the left to the right, first along the upper shaft, then along the lower one. Remember the length of the shafts and then reproduce it by the movement of the index finger of the empty screen after the shafts disappeared. The person leading the experiment pressed a button on a keyboard after a participant moved his hand across the shafts of the sensory motor task and stimuli disappeared. Immediately after the disappearance of each stimuli, the participant moved her right hand across the touchscreen monitor. First along the place of the upper shaft and then along the place of the lower shaft from the left to the right. The experiment was performed without feedback. Two pathways are involved in the processing of visual information in the brain, dorsal and ventral stem. It is believed that the visual information related to movement, which we studied in the motor assessment task, is processed in the dorsal pathway, and the task with verbal estimation of the length of the bars is associated with the ventral pathway. This slide describes how we calculated the power of the illusion. So, in the adjustment task, the estimation of neutral stimuli of all three groups don't differ from each other and from zero. At the same time, the Müller-Ley illusion exists in all groups of participants. It is significantly stronger for the resistant group than for the normal group and for non-resistant group. The same pattern of result was received for the Ponzi illusion. It exists in all three groups and is significantly stronger for resistant group than for normal group and for non-resistant group. The sensory motor estimation of neutral stimuli as well as the Ponzi illusion don't differ from zero and from each other of the memorization phase in all three groups. The Müller-Ley illusion significantly differs from zero in each group. The sensory motor estimation of neutral stimuli don't differ from zero at the reproduction phase in all three groups. Meanwhile, the overestimation of the upper shaft of the neutral stimuli is more pronounced in non-resistant group than in normal group and in resistant group. The Müller-Ley illusion significantly differs from zero in each group. The Ponzi illusion exists in all three groups and is significantly weaker for normal group than for non-resistant group and for resistant one. When assessing the association of mean illusion strength with clinical data, we obtain significant negative correlation only with age and the estimate on score subscale for both illusion and negative correlation with stereotype thinking, poor attention, and lack of judgment and insight with the motor task of the illusion, Ponzi illusion. No significant association with one's productive symptoms were found. So our result confirmed that patients with schizophrenia can be either stable to visual illusions or have a high sensitivity as stated above. It may depend on the mental state. In order to understand the influence of the severity of the mental state of the susceptibility to illusions, our next step is to plan a longitudinal study. significant difference in the patient group in both the adjustment task and motor task as compared to healthy subject indicating impairments of patients with schizophrenia indicate impairments in both ventral and dorsal visual pathways. Visual illusions can be a potential biomarker of the mental state in schizophrenia patients. That's all. Thank you for your time.
Thank you. Please ask your questions. Maybe somebody accept. Evgeny.
A lot of questions. I have one question about your study. It's very interesting. I heard it, I think, last year, and it was such a opening for me. And I want to ask about other receptors, about, for example, not only visual, for example, nasal or dermatological, dermoreceptors, I think. Are patients with schizophrenia have a higher sensitivity in other systems too, or not?
Can I answer in Russian?
Конечно.
Недостаточность в различных перцептивных системах пациенты выявляют, мы изучали и обонятельную систему, и тактильную чувствительность. Во всех этих системах мы получили подтверждающие данные. Но они широко известны, были еще известны и в прошлом веке, но изучение их затруднялось в связи с тем, что не было методов, которые позволяли их хорошо измерить. На сегодняшний день существуют для измерения обоняния стандартизированные тесты, к сожалению,
благодаря
мы не смогли приобрести такие. Да, для изучения тактильной чувствительности их тоже очень много тестов, как и для зрительной системы. И то, что сейчас, раньше было известно и говорилось, что пациенты с шизофренией имеют сниженную чувствительность, то есть пороги у них ниже, чем у здоровых. На самом деле и в наших исследованиях, и в других исследованиях последних лет мы видим, что пациенты с шизофренией гетерогенны, как говорится, и они, может быть, это зависит от психического состояния. Иногда мы находим такие факты, иногда нет, но...
Там у вас с какими-то с галлюцинациями были корреляции, да?
Да, были корреляции и обонятельных нарушений. Они очень хорошо коррелировали и показывали вот эту гиперчувствительность, потому что мы использовали чувствительность к N-бутанолу, и для N-бутанола в стандартизированном тесте используется тоже N-бутанол, и там пороги фиксированные. Есть от чего-то, типа, что говорить, где и когда есть гиперчувствительность и сниженная чувствительность. Для других методов это немножко затруднено в связи с отсутствием такого большого изучения. И когда мы поделили пациентов, мы видели, что пациенты там, с гиперчувствительностью явно демонстрировали корреляции с продуктивными симптомами, с галлюцинациями, с бредом и так далее. Что касается иллюзорного восприятия, то пациенты с шизофренией, многие исследования это подтверждают, что могут больше сила иллюзий зависит от бредовых убеждений, намеренных попасть. То есть очень часто коррелируют. Но в наших данных на данный момент мы такого не нашли. Это в рамках, интерпретируется в современной литературе в рамках нарушения предиктивного кодирования, основанного на теореме Байеса. Это требует моделирования и так далее. Мы надеемся, что когда-нибудь к этому придем, пока мы собираем материал.
Спасибо, очень интересно.
Okay, thank you very much.
Thank you.
The next presentation is from Елена Эдуардовна Вайман, junior researcher of the Personalized Psychiatry and Neurology Institute of Bechterev's National Center of Psychiatry and Neurology. The presentation will be about the pilot study of assessment of abnormal involuntary movements according to the scale in patients with antipsychotic-induced tardive dyskinesia. Please.
Hello everybody, let me introduce my report. So the extrapyramidal disorders form the so-called extrapyramidal syndrome, which is characterized by the occurrence of motor disorders as a result of damage of basal ganglia and subcortical thalamic connections in the brain. Extrapyramidal disorders are divided into the primary and the secondary. The primary are acute dystonia, Parkinsonism, acute epiphysia, early tremor, malignant neuroleptic syndrome. And the secondary are the tardive dyskinesia, tardive akathisia, late tremor, late myoclonus, and late tics. So on this slide, we can see which drugs can cause extrapyramidal syndrome. And the first reason is taking antipsychotic. So on this slide, we can see that antipsychotics divided into the two groups, first and second generation, and also we can divide them as the risk of the development of antipsychotic-induced tardive dyskinesia, high, mild, and the low risk. So antipsychotic-induced tardive dyskinesia are divided into the early or acute. It is a hyperkinesis that occurs in the first hours or days after taking antipsychotic, and the late or tardive dyskinesia. It is a hyperkinesis that occurs while taking antipsychotic more than 4 weeks. Tardive dyskinesia is divided into the reversible, which is characterized by complete regression of hyperkinesis within months or years, and persistent, has a persistent curve. So we need the two criteria of tardive dyskinesia. It is symptoms which occurs as a result of long-term use of antipsychotic and persistence after antipsychotic withdrawal. The risk factors of antipsychotic-induced tardive dyskinesia are the elder age. The symptoms occurs in patients elder than 60. The female has the symptoms more than 25 times more than the male. The race and ethnicity, genetic facts, long-term use of antipsychotic, the use of antipsychotic with dose release, emotional disorders, cognitive disorders, alcohol addiction, psychoactive substance dependence, smoking, use of lithium and anti-Parkinsonian drugs, comorbidities, and early appearance of antipsychotic-induced extrapyramidal syndrome. The frequency of occurrence of antipsychotic-induced tardive dyskinesia varies from 0.85 to 50%, and the peak of incidence is in Russia. The main theory of antipsychotic-induced tardive dyskinesia is blocking of dopamine receptors. So typical antipsychotics blockade the dopamine receptors D2, and the atypical antipsychotics blockade all dopamine receptors and the serotonin receptors. The clinical picture of antipsychotic-induced tardive dyskinesia is a hyperkinesis in the muscles of the tongue, face, lips, or pharynx, jaw, neck, diaphragm, trunk, upper and lower limbs. Also, we use the scales for assessing the symptoms antipsychotic-induced tardive dyskinesia, and the famous scales are the abdominal involuntary movement scale, and Simpson-Afton scale, and extrapyramidal Simpson rating scale. Of course, we use a laboratory diagnosis, instrumental diagnosis for differential diagnosis. And the purpose of our study is to study the incidence of abnormal involuntary movement, assessing according of abnormal involuntary movement scale in patients with schizophrenia of antipsychotic monotherapy. We assess the patients of European race from 18 to 60, which permanent resistance in the northwestern region of Russian Federation, diagnosis schizophrenia, and all patients took antipsychotic or monotherapy mode. The sample was 76 patients, 28 are men and 48 women. On this slide, we can see which antipsychotics patients took. Most of all, they took olanzapine, haloperidol, and paliperidol. Of these 76 patients, 41 had involuntary abnormal movements, and predominantly it was minimal severe. The hyperkinesis was in the muscle of tongue, predominantly 41 patients had it, and facial muscles and jaws. One patient had disability due to abnormal movements, and 2 patients have aware of the presence of adverse reaction. Our aim was to study these patients 2 times for a long period, and after exclusion we had 27 patients, and 14 had involuntary abnormal movements. So in first visit, the involuntary movements predominantly were mild severity, and they were in the tongue, mimic muscles, and jaws. 1 patient had disability due to abnormal movements, and 2 patients were aware of the persistence of adverse reaction. And the second visit was after the 8 weeks, and 14 patients had involuntary abnormal movements, predominantly they were minimal, and they were in the tongue, mimic muscles, and the jaws. After 8 weeks, no patient had disability due to abnormal movements, but only 1 patient had aware of resist of adverse reaction. And in conclusion, we can say the frequency of occurrence of involuntary abnormal movements characteristic of antipsychotic-induced static dyskinesia in patients with schizophrenia according to the aims is 53.9%. Severity of involuntary abnormal movements was predominantly minimal and mild, and there was no statistically significant trend towards in increasing the number of cases and no statistically significant increase in severity. Thank you for your attention.
Thank you.
Thank you. Questions, please.
Tardive dyskinesia is your theme of the first scientific work.
This was 6 years ago. I forgot all. We have a psychopharmacologist in
Yeah. Okay. The first question is, what do you think is optimal strategy for correction, if it's needed?
So first, we can reduce the dose of antipsychotic. The second, the change antipsychotic for alternative, it's possible, and the third stage is corrections drugs.
What drugs corrections?
For tardive dyskinesia, it's MAT2, tetrapeptidine in Russia, amantadine.
Thank you. Yeah.
Thank you very much. Yeah.
Okay. Yes, our next presentation. The speaker is Всеволод Владиславович Severtsev, the PhD resident of Sechenev's University. The presentation will be about psychotic disorders associated with synthetic cations usage.
Thank you very much, dear colleagues. Hello. I'm glad to present you the results of our study. Let's move on. Synthetic casinons is a modern synthetic psychostimulants that are well known by the street name bath salts, and they have similar effects as more classical psychostimulants such as amphetamine, methamphetamine, and MDMA. According to European Drug Report 2021, synthetic casinons was the second by their abundance in Euro Union. Up to 20% of people between ages 14 and 24 in UK used synthetic casinons at least once. In Russia, since 2015, number of patients with stimulant dependence increased for 30%. In Bashkortostan, alpha PVP and MDPV made 75% of all synthetic psychoactive substances. that was found in blood samples. Synthetic catenols drew the attention to their ability to lead to development of psychosis. We suggested that psychosis associated with synthetic catenols usage has multiple forms. These forms have different clinical and dynamic features, and that the choice of therapeutic tactic depends on form of psychosis. Study included 176 patients. 64.8% were male, 35.2% were female. Median of age was 27 years old, so that was young people. And there was no gender differences in groups. We used following scales and questionnaires to assess patients' condition. First, multi-dimensional fatigue inventory, brief psychiatric rate scale, and World Health Organization quality of life scale. For toxicological analysis, we used gas chromatography mass spectrometry, and results were statistically proceed. Included patients met following ICD criteria for diagnosis poisoning by other and unspecified psychodysliptics. They made 65.9%. Psychotic disorder due to use of other stimulants, including caffeine, 10 and they made 10 and 2%. And dependence syndrome due to use of other stimulants and including caffeine, they made 23 and 8%. Patients who was included, they was hospitalized to Department of Acute Poisoning, to Department of Intense Care, Narcological Intense Care, and common narcological departments. Synthetic catenols was detected in biological samples by GCMS, and we didn't include patients who met next criteria, previously diagnosed with schizophrenia, schizoaffective disorder, or epilepsy. If their statement associated with other diseases made their participation impossible. Also, we didn't include patients with syphilis or HIV positive patients and pregnant women. There visualized the design of the study. All participations at the first visit was examined with using BPRS scale, and we took biological samples to proceed toxicological analysis. After that, patients were divided into the two groups by the presence or not presence of psychosis. And after that, patients were observed until the psychosis stops. After psychosis stopped, there was a third visit. We made a second examination with using all the scales and questionnaires. After that, results were statistically analyzed. Let's move on to study results. We found the risk factors of development of psychosis. First of all, patients in psychotic group were older. So older patients experienced psychosis more often. Also, we found out that patients who used synthetic catenols from 1 to 14 days experienced psychosis in 50% cases, and if patients use synthetic ketanons for months and more in a row, rate of psychosis was 75%. And also we found out that alpha-pyroberderone and mixtures that contains it led to development of psychosis more often. After that, we divided patients into subgroups by their clinical condition. First subgroup we conditionally named delirium tremens because their statement was quite similar to classic delirious trait. They had global confusion, intense hallucinations, and physical symptoms such as hypertension, tachycardia, and hyperthermia, etc. The second group was conditionally named delusion, and patients in this group had acute non-bizarre paranoid delusion with ideas of perception or jealous delusion. And the third group was formed with patients with complex symptomatic. They had delusional of control, pseudo hallucinations, bizarre delusion, and also they had affective disorders. But all forms had common symptoms such as psychomotor agitation and an intense sense of fear. And commonly this statement was accompanied with hetero or autoaggression. So delirium tremens form developed in 55 and 1% of cases. Polymorphic form developed in 24 and 5% cases, and delusion form developed in 20 and 4% of cases. There was different period of development in different forms of psychosis. Delirium tremens form developed only during intoxication. Polymorphic form developed in 75% during intoxication, 60 and 7% during withdrawal, 8 and 3% after absence period more than 10 days. And delusional form developed in 90% during intoxication and 10% during withdrawal. As I said previously, delirious form was the most acute, most severe, and it affected BPRS score. Clinically, patients with other forms of psychosis showed higher insight and was less agitated. That's why their score was lower. But delirious form lasted usually up to 3 days, and delusional and polymorphic forms often lasted about a week and up to 23 days. All patients, including psychotic and control group, experienced fatigue symptoms. But patients in psychotic group has higher fatigue score. Also, fatigue symptoms was most severe in patients with polymorphic form. Delusional form was the second, and delirious form was the third. psychotic patients reported of worse psychological and physical condition, and lowest scores of physical and psychological condition was presented in patients with polymorphic form. After that, we compared therapeutic tactics. First three tactics are usual and common in psychiatric and neurological departments. They included isotonic solutions infusion up to 2 liters per day. And first tactic included also benzodiazepines. Second tactic included using first generation antipsychotics. Third tactic included using second generation antipsychotics. And fourth tactic was common in Department of Intensive Care. Isotonic solutions infusion was there up to 4 liters per day, so there was massive infusion, and they used such medication as propofol up to 1,000 milligrams. We found out that all the therapeutic tactics was effective because BPRS score in day 10 didn't show significant difference between them. But the most of the tactics was available to relieve symptoms in 5 days. But tactic in which second generation antipsychotics were used showed lowest dynamic and psychotic symptoms lasted much longer. Tactic where benzodiazepines was widely used to treat delirious and delusional form. Tactic where first generation antipsychotics were used was common in all forms. Tactic where second generation antipsychotic was used only to treat delusional and polymorphic forms. And tactic where propofol was used in the third part of cases was used to treat delirious and polymorphic forms. And our findings. That's the last slide. Psychotic disorders associated with synthetic retinoids usage is heterogeneous group of psychosis that has at least 3 forms: delirious, delusional, and polymorphic. In the most of cases, psychosis appears during intoxication, but polymorphic and delusional forms can be found during withdrawal syndrome or after 10 days of sobriety. Delirious form is most common. It has good therapeutic response and as a rule stops in 3 days. Delusional and polymorphic forms often requires longer period of medication and stop in 8 or 10 days. Prognosis for these patients with polymorphic form is least positive. In this form, psychotic symptoms and post-psychotic disorders linger longest. All of the therapeutic tactics are effective. Usage of second-generation antipsychotics associated with longer medication period. But conclusions about therapeutic tactics are preliminary and further study is required.
Okay, thank you.
Thank you. Any questions? Yes.
Thank you for the presentation. Very good. I have several questions. First one is about non-inclusion criteria. Could you please explain us why you decided not to include patients with syphilis or HIV infection
Well, pregnant patients wasn't included to prevent some ethical problems. And with syphilis or HIV, I understand that the point of your question that they are similar to all other patients, but there are some theoretical thoughts about that they could have some organic changes, differences to comparing to not infected patients.
In this case, I would like to continue. You told that one of non-inclusion criteria was diagnosis of schizophrenia or schizoaffective disorders, but what about bipolar disorder?
We included these patients. The point is that this is the first part of the study, and we continue it and looking for onset of schizophrenia, or if these patients will be diagnosed with schizophrenia after after this first, or not first, but this psychoactively induced psychosis.
No, really, your study is really interesting. That's why we have questions. The second one was about these forms you identified. You told that there are your clinical features that helped you to identify 3 forms of psychosis. So please, would you explain us how exactly you did it? You use some statistical methods, or you use some structural questionnaire? How you evaluate psychological symptoms which lay on the basis of these 3 forms? Or it was just like empirical method?
Well, there was first of all empirical observation, and we understood that we have such groups, such subgroups. But when we did statistic analysis with the duration of this psychosis, when we looked at other features of these subgroups, we found that there was also differences between them. So you
provided regression analysis.
What?
You provided regression analysis.
We provided analysis of other features like duration, like BPRS scores, and understood that there are differences in these groups by other features. So I don't know, maybe maybe there are, but I don't know if there are some questionnaires that can divide patients with such different symptomatology. Symptoms.
Okay, dear colleagues, I think we have time limitations. Yeah. It's very
interesting,
complicated discussion. Yeah. You should continue later.
I also have one question, and later I ask you after our symposium. Thank you very much. Next speaker, Dmitry Sergeyevich Rodionov, junior researcher of Department of Treatment, Borderline Psychotic Disorders and Psychotherapy. Yeah, understood that was old term for, okay, neurosis. Yeah, of our center. And the theme is the comorbidity of anxiety disorders with alcohol use disorders, clinical and psychological features.
Neurosis joke. Yeah. Greetings, dear chair, peoples, dear colleagues. Thank you for the opportunity to hold my speech in my horrible, terrible English. Today I would like to bring to your attention a project draft of the forthcoming study. My name is Dmitry Rodionov. I'm Junior Research Associate of Department on Non-Psychotic Mental Disorders and Psychotherapy. And my work's name is The Comorbidities of Anxiety Disorders and Alcohol Use Disorders, Clinical and Psychological Futures. Okay. About actuality, recent population-based studies in the ACD-10 and using the ECD-11 and DSM-5 diagnostic criteria show that about 20–30% of the world's population suffer from some kind of anxiety disorders in their lifetime. I should know that there is a high risk of comorbidity between active anxiety disorders among people with alcohol use disorders of about 30–40% according to the meta-analysis. You can see in the slide this information. There is an increased risk of somatic diseases. This is the social and medical problems of this comorbidity. When we said about risk of somatic disease, we must think about it when we choose treatment, psychotherapy or combination with pharmacotherapy. This is increase of suicidal behavior by patients with this comorbidity, and the economic cost of care for these patients about 30 billion euro per year. I must say, pay attention to the slide. The current reality in pandemic and COVID pandemic included increase in alcohol consumption. For example, in Russian regions during the pandemic, increased consumption of alcohol surrogates. I think it's hang on socio-economical situation, but it's reality. It's modern statistical research from Lancet about epidemiology, alcohol consumption in Russia during pandemic, and you can see increase of anxiety disorder in patients with COVID. And of course, the actuality is also indicated by biological research that I think about it can say our experts of affective disorders better than I. There's ongoing work on the stress and neuroendocrine regulation relationship. For example, evidence is accumulated on the role of the central amygdala as an integrative hub of anxiety and alcohol use disorder. You can see in the slide addictions, cycle stage associated brain regions from some scientific sources. Our work draft of study will be more psychological aspect. A review of scientific sources was able to identify three main clinical variations. First variation, you can see that when anxiety disorder and hence the risk of alcohol abuse and alcohol use disorders. When we say about it, we can think about psychological mechanism. For example, coping behavior by patients with anxiety disorder is so important when we choose treatment. Second variant is when alcohol use disorder increases the risk of anxiety disorder. For example, our Soviet scientists from Bechtereva Institute, Melik Pasadanov, worked about this problem, and we can see spontaneous remissions of alcohol use in the development of anxiety disorder. Then spontaneous remissions by patients who abuse alcohol after development by these patients and anxiety disorder. And third variant is a comorbidity separate psychological unit. For example, you know, in Russian traditional psychiatry school, Pятницкого-Portnov, neurostatic first stage of alcohol dependence, when anxiety separates symptoms in structure of alcohol use disorders. Of course, more studies focus on the social and clinical psychological characteristics of patients with comorbidity. There are knowledges of gender and age-specific comorbidity, and for example, for us, it's so important in this work, relations with mental trauma in the past. Focuses on the role of coping behavior, I said about it, and coping strategies and the development of alcohol abuse in anxiety disorders. And so important, this is knowledge of effectiveness of psychotherapy and of a combination of psychotherapy and pharmacotherapy. I should mark, I say about motivation groups, for example, 12 steps, or cognitive behavior therapy group or individual. Yes, on the available databases, the main tested hypotheses were formulated by us. This is a correlation between anxiety disorders and the level of alcohol consumption in patients. I think about it, say, per next speaker, colleague. It's important to identify the primary disorder, anxiety or alcohol use disorder. What's primary? Co-occurrence of anxiety and alcohol consumption, and this dynamic is associated with certain individual psychological characteristics that may be both positive or negative predictors, for example, chronicity of disorder or formation of alcohol dependence by these patients with anxiety disorder. A complex assessment of the clinical psychological characteristics of patients with anxiety disorder and their level of alcohol use is important in determining the prognosis of disease, the possibility of chronicity, and the formation of alcohol dependence, and determining the content of treatment, rehabilitation, and prevention measures. I said about it. Pay attention to the slide, please. The aim and objectives of the study were formed-based hypothesis. This is inquiry, the comorbidity of anxiety disorders and alcohol consumption. And a little bit about study design, our draft. We didn't study yet. This will be a retrospective study among patients with anxiety disorders with established diagnosis of anxiety disorder. The slides presently used ICD-10 criteria. It's real anxiety disorder F30. There are main groups, 4 main groups, distributed according to the level of alcohol consumption. I should mark that this level of alcohol consumption based World Health Organization criteria. You can see it, it's not closed. And 2 control groups. First group, people without anxiety disorder who use alcohol. Second group, people without anxiety disorder who do not use alcohol. We said about these people, these healthy people, but I think that's true that they haven't only anxiety disorder. Maybe. The study will consist of 3 stages. The first stage is a screening without the search of potential participant with inclusion and non-inclusion criteria. I must note that is important. I said about it, the participants should have an established diagnosis before included in study. No psychotropic therapy, no psychotherapy including anti-alcohol therapy before 1 month inclusion in the study. The ability to give right informed consent, of course, in our realities. Patients with a severe intellectual and mental decline, as well as presence of stage 3 alcohol dependence and severe acute or chronic somatic pathology are not included. It's important to note the non-inclusion criteria is increase of suicidal suicide risk. The second stage include 3 parts using a semi-structured interview and recording the results in the development clinical anamnestic card. Objectivization will be means of experimental psychological inventory. For example, it's psychometric examination, psychological testing. You can see this slide, Columbia scale, Hamilton scale, symptomatic questionnaire, Alexandrovich. It's self-translate of this name of questionnaire, integrated insight test, neurotic personality questionnaire, level of neuroticism and psychotization. This is test part of MMPI, a 5-factor personality model. And I must note in the study will be used retrospective analysis of alcohol use with timeline follow-back scale. And during the phase, we will collect basic data, social demographic, clinical anamnestic, clinical psychological, I said about more information and scientific sources about relation with gender, with age specifics by patients with alcohol consumption and anxiety disorder. And then we will assess the alcohol consumption before and at the time of inclusion in the study. And of course, it's for us not more interesting, but so important part, statistical processing and analysis of the data obtained in the order to determine the relationship between the characteristics of alcohol consumption and the dynamics of the course severity of anxiety, and to investigate the dynamics of comorbidity. It was our draft or protocol, if you want, of our study. If you have suggestions or commenters, I try to hold our connection. Thank you for your attention.
Thank you. Any questions? Yes.
Okay.
Thank you for your presentation. And the first question is, how did you calculate the sample size?
Okay, yeah. I think it was. Okay. Do you mean?
120.
Yeah. Do you mean it? We thought about we will have two groups. This is episodic anxiety, for example, it's panic disorder and generalist anxiety. This is generalist anxiety disorder. In every part, real 60 patients. It's not evidence numbers simple.
In general, do you have only two groups?
No. Because we have two groups. I mean symptomatology, episodic anxiety and generalist anxiety. Every group alcohol levels, and for two control groups.
And how did you calculate this sample size? Is this only your design?
No, I mean it's only group of respondents. No.
You have data of 120 patients, yes?
Yes.
Okay.
Okay. Yes, and I would like to suggest to
how you did it.
No, to study also family history of alcohol consumption or anxiety disorder, or mood disorder, because this is a very
in social demographic part.
This information will be in anamnestic card.
Yeah. And in this, are there any information about family history in this?
Yes, of course. It's so important if, for example, we have patients with anxiety disorder, but in anamnesis family history was, for example, bipolar disorder. It's not still clean results. Yes, it's so important. Yeah. It will be information.
Can I ask a question? As I know, it's always a problem to evaluate how much alcohol patients consume, because they can decrease. How you will manage this?
It's so interesting question, but I can ask you. I said that these patients will be in walls of this, for example, hospital, and we will give patients this scale when patients can say about these portions timeline for back. But it's so important, we will not take patients with primary diagnosis of alcohol addiction diagnosis, only neurotic anxiety disorders from our from our in English. Yes.
Okay, my suggestion maybe I'm not narcologist definitely, but maybe you can ask their relatives also about their consumption. Maybe
yes,
it can be
this information we conclude too. This part, this first part of screen, we how can English? Собираем, да.
Maybe this, maybe narcologist, GGT, GGT, yeah.
We will work with addiction doctors, with narcologists too in our team, and clinical psychologists, not only psychiatrists, narcologists too. Addiction.
Maybe gamma GDT for testing if they are really hard consumption alcohol.
It's better.
Just suggestion.
Yeah.
Yes, you ask.
Do think about it.
I have one more word about design of your study. I think you have a lot of skills, too much skills.
Yeah, I think about it to 1 week ago when I make a presentation, and then after this horrible English speech, I will think about skills. Yes.
Yeah, it can take too much time. I think maybe
yes.
Some questions are similar. So
I think a part of questions from, for example, questionnaires will be in card. About anxiety disorders, about symptomatology, but it's only draft.
Yeah.
More, it's not little.
Okay, thank you.
Thank you.
Thank you.
Okay. Introduction.
Okay. Dear colleagues, we should continue our work, and the next speaker here is Tamara Merkulova. She is from Moscow. She is research assistant. Research assistant in laboratory of molecular genetics from Serbsky Center, and the report is association between family history, degrees of alcohol dependence, and anxiety level in healthy young adults. The floor is yours.
Thank you. Hello, dear colleagues. As it was said, I want to present you our study, association between family history of degrees of alcohol dependence and anxiety levels in healthy young adults. First of all, about background. About terminology, family history or family burden is the fact of case or cases of a particular disease in patient's blood relatives. And population prevalence of family history of alcohol dependence estimates at 10 to 20% in general population, 50 to 85% in patients with alcohol dependence in USA, and 60 to 70% in patients with alcohol and opioid dependence in Russian Federation. Also, the prevalence of anxiety disorders in general population estimates 2 to 8%. And 36 to 61% of patients with substance dependence. Family history of alcohol dependence may also contribute to a higher probability of psychiatric disorders such as anxiety disorder, and anxiety symptoms may be a possible predictor of substance dependence also at the preclinical stage. So, hypothesis of our study is that the severity of anxiety symptoms may be higher in person with family history of alcohol dependence, and perhaps the severity of anxiety may be proportional to the degree of family history. And the aim is to test an association between family history of alcohol dependence and its degree and anxiety levels in healthy young adults. So now about methods. The participants of the study was healthy volunteers, and all information about participants were obtained by completing self-questionnaire by participants. Here you can see inclusion criteria, its age from 17 to 32 years, and lack of mental disorders and addictions. Non-inclusion criteria is severe somatic diseases in the stage of decompensation, and exclusion criteria is a request for exclusion from the study. About self-questionnaire, it includes socio-demographic characteristics, age and sex, and family history of alcohol dependence present and degrees. And also they fill the hospital anxiety and depression scale, which includes two subscales, HADS-D for depression and HADS-A for anxiety. And HADS-A provides for estimation of anxiety both in score and terms of severity. Categories is 0 to 7 points is non-anxiety, 8 to 10 points is borderline anxiety, and more than 11 points is clinical anxiety. The study is cross-sectional. Participants were divided into groups with and without family history of alcohol dependence, FH and FH0. And these groups were compared for all study variables. Further, to identify possible effects of the degree of family history of alcohol dependence, the FH group with the family history of alcohol dependence were divided into two groups with the moderate degree of family history of alcohol dependence and a high degree. Moderate degree means that the participant have one relative with alcohol dependence, and high that participant has two or more relatives with alcohol dependence. About statistic analysis, we used one Whitney test for quantitative variables, Pearson's chi-square test for categorical variables, and generalized linear model for sex adjustment. Results. The study, as I said before, was conducted among healthy volunteers. There was 95 persons in age 20 to 68 years, and 80% of the participants were women. You can see in the diagram that 45% of participants had no family history of alcohol dependence, 21% have a moderate degree of it, and 34% have high degree of it. And there was no difference in sex and age between these comparison groups. Now about comparisons. First comparison was persons with and without a family history of alcohol dependence, and we find out that persons with a family history of alcohol dependence are more likely to have symptoms of anxiety. In particular, they are more likely to have borderline and clinical anxiety symptoms, and also they have a higher average HADS score. When we compared persons with a high degree of family history of alcohol dependence and persons without this family history, we find out that persons with a high degree of it have more often have anxiety symptoms. In particular, they're more likely to have borderline clinical anxiety symptoms as in previous comparison, and they also have a higher average HADS score. But when we compared persons with a moderate degree and the persons without family history of alcohol dependence, we find no difference. And when we compared persons with a moderate and high degree of family history of alcohol dependence, we find out that the persons with a high degree more often have anxiety, in particular clinical anxiety symptoms, and they have a higher average HADS-A score, and this result was confirmed after the construction of the DLM adjusted for sex. To conclusion, we find that a high degree of family history of addiction provides to more anxiety prevalence and severity of anxiety, and So family history associated with more pronounced severity and prevalence of anxiety in healthy young adult deaths. Various of anxiety is proportional to the degree of family history of alcohol dependence, as we thought, and it's mean that our hypothesis was confirmed. The limitations of the study was that 80% of participants were women, and anxiety, family history of alcohol dependence, and its degree were assessed by self-questionnaire, and our findings should be confirmed in larger cohort. And acknowledgements for the colleagues from the Serbsk National Medical Research Center and staff all study participants.
Thank you. Any questions? Yes, please.
Thank you for the presentation. How do you think you can apply your results in practice?
Maybe after research in a larger cohort, we may form some risk groups for psychiatric disorders and substance dependence when we will confirm our results that family history of alcohol dependence really associated with these things.
Thank you.
First of all, it's very nice study, clear methodology, very nice.
Thank you.
And now I have sophisticated question. What do you think? The alcohol consumption among relatives, of course, have their biological side, but of course it has psychosocial side. Yeah, because when some of the parents drinks, it brings a lot of disturbance in family system.
Yeah.
What do you think? There is more biological problems or there is more psychosocial problems?
I think both of it. Of course, genetic is very important, and social factors too. So I think really both of it. There is conceptions of gen and environment interaction, and I like this topic.
Maybe in larger cohorts it can be something for differentiation. For example, if we just take the relatives that is, I don't know, cousins or some maybe grandfather which were living in some country and didn't communicate with patient, it's one thing, and that thing when and mother and father both drank a lot, maybe it can be distinguished between biological and psychosocial.
We know in the study we know which relatives have alcohol dependence, but it wasn't included in the presentation.
Yeah, maybe in larger cohorts it will be interesting to investigate. Thank you.
Thank you.
One question.
Okay.
Yeah. I really like your research. I agree with Sergey. Very nice study. Very nice idea. But I wonder, there is a lot of information that people with a lower economical state have much more problems with mental health. So I think that heavily dependent persons in family have high risks with low economical state. So did you analyze among socio-demographical characteristics other than sex and age? Or something else?
Yeah, we have a large phenotype, and we know that all our participants were a student of Moscow University, and about economic status, we don't know this information, but it's interesting topic, so maybe we can make it better.
Thank you.
Thank you.
Any other questions?
Yes. Could you return slide, please, with the result of general linear model? 2 slides ago.
wait,
Yeah.
Here.
Yeah.
There's no graphs or diagrams with GLM only.
Why did you choose this method for adjusting the sex?
Yeah.
And this is also recruitment. However, but just why didn't you use multiple linear regression or ANOVA, because GLM is very difficult method, and I learned this method, and we can only predict, and we cannot say that there are no important differences between male and female if you use GLM. Do you conduct statistical analysis?
Yeah, but I used SPSS,
yes.
Not R.
Yeah.
I know that it's more difficult in R, but in SPSS I think it's...
Okay. We will discuss after.
Okay.
Thank you.
Thank you. Any other questions? No?
No.
Thank you very much.
Thank you.
Okay. The next speaker is Maria Alexandrovna Habeish, junior researcher of integrative pharmacopsychotherapy department of Bechterev's National Psychiatric and Neurological Center. The topic will be psychiatric stigma in patients with schizophrenia spectrum disorders and concomitant HIV infection. Please.
Hello everyone, dear colleagues. I guess everybody's tired, so I'll try my best to be short. Thank you for the opportunity to present my report, Psychiatric Stigma in Patients with Schizophrenia Spectrum Disorders and Concomitant HIV Infection. And I would like to start my report with the two quotes. The most common consequence of mental illness is the experience of shame. And the second one, if we do not take into account the nature and consequences of stigma, none of our event will not succeed. AIDS is perhaps the most stigmatized disease in history. I think these two quotes demonstrate the extreme importance of stigma issue. Back in early days, 1963, Irving Goffman's book Stigma Notes on the Management of Sport Identity inspired a profusion of research on the nature, sources, and consequences of stigma. Stigma can be seen as a relationship between an attribute and a stereotype. In other words, stigma is a mark that links a person to undesirable characteristics. Stigma exists when elements of labeling, stereotyping, separation, status, laws, and discrimination occur together in a power situation that allows them. Stigmatization in psychiatry is a global phenomenon that goes beyond the limits of clinical practice, including various universal human relations. So when we talk about prevalence of mental illnesses, stigma, we see that it's really high. Systematic reviews say us that about 22% of patients with bipolar disorder and depression has moderate or high levels of self-stigma. About 72% have moderate or high perceived discrimination. We know that rates of anticipated or perceived stigma ranged from 33.7 to 80% in interpersonal interaction. An average of 64.5% of patients had perceived stigma. Almost 60% actually had experienced stigma, and about 50% reported alienation or shame, as we saw before in first quote, and the most common aspect of self-stigma. So, stigma against mental illness is a complex construct with affective, cognitive, and behavioral components. As we said before, there are three components of stigma: stereotypes as cognitive response, prejudice as affective response, and discrimination as behavioral response. Stereotypes are especially efficient social knowledge structures that are learned by most members of social group. Prejudices are based on stereotyped beliefs, colored with a special emotional tone of neglect and depreciation, both in personal and social contexts. And discrimination is the heavily realized prejudice that favors differentiated, special attitude to people with mental illnesses. But stigma can be classified by types into three groups, into three types: public stigma, self-stigma, and institutional or structural stigma. So public stigma involves the negative or discriminatory attitudes that others have about mental illness. Self-stigma refers to the negative attitudes, including internalized shame that people with mental illness have about their own condition. And institutional or structural stigma is the most complex phenomenon. It is more systemic, involving policies of government and private organizations that intentionally or unintentionally limit opportunities for people with mental illnesses. But it doesn't matter, is it public or self-stigma, it still has the same structure based on stereotype, prejudice and discrimination. But as you can see, when we talk about public stigma, prejudice as agreement with beliefs or negative emotional reaction can be realized in anger or fear. When we talk about self-stigma, prejudice can be realized in low self-esteem or low self-efficiency. Another issue we have is stigma among mental health professionals. A systematic review consisted of 38 articles published from 1999 to 2019 and involving more than 10,000 mental health professionals, says us that mental health professionals are considered to be one of the main sources of stigmatization of mental illness. And studies show that schizophrenia is one of the most stigmatized mental illnesses by MHP. In comparison with other social groups, MHP reported less dangerousness beliefs and more positive beliefs regarding pharmacological treatments, but nevertheless, results were less consistent regarding prognosis and desire for social distance. And in my point of view, their desire for social distance is a really big issue. I hope it will change. We all know about consequences of psychiatric stigma, that there are plenty of them, but this table is presented to show you how we can measure outcome of negative consequences of psychiatric stigma at different periods of disease, at different stages. So we can see that on the individual level, at onset of symptoms, symptoms denied, and patient can decline all trying to presentation to psychiatrist, and at for example at diagnosis stage we see that the self-stigmatization consequences as shame, sense of failure, negative automatic thoughts, and we see that at post-admission stage there are much more consequences as victimization, as loss of employment, and even a higher suicide risk. Stigma across HIV, mental illness and physical disability can be occurring and may interact with other forms of stigma related to social identities like race, gender and sexuality. So yes, stigma is really complex phenomenon, and it depends not only on disease, it depends on social, demographical features and so on. Stigma is especially problematic for people living with this condition because it can create barriers to accessing necessary social and structural support, and in this case, I don't even mention access to treatment. Now we know that over 37 million people globally were living with HIV in 2020, and over 600,000 people died from AIDS-related illnesses in 2020. There are studies on the stigmatization of patients with HIV infection and associated drugs use, but they measure stigmatization primarily by HIV status, and they do not measure psychiatric stigma. Psychiatric patients demonstrate a high level of self-stigmatization compared to HIV people, and this finding can be explained by the presence of public anti-stigmatization programs for HIV-infected people. So HNV people with concomitant mental illness may have difficulty with access to HIV treatment. So hypothesis of the study was the assumption that HIV infection in psychiatric patients contributes to the psychiatric stigma structure. In our cross-sectional study, aimed to study the features of psychiatric stigma in patients with schizophrenia spectrum disorder and concomitant HIV infection, we examined 70 patients with schizophrenia spectrum disorders, patients of 4 hospitals of St. Petersburg. You can see inclusion criteria, non-inclusion and exclusion criteria. Methodology includes clinical interview, psychometrics, Bechtereva scale, psychological methods, internalized stigma of mental illness scale, perceived evaluation and discrimination scale, and revised social anhedonia scale. But before proceeding to results, I would like to stop and say a couple of words about the scales, because systematic measurement of internalized stigma provides clinician and clinical researchers with confirmable and viable target for general psychotherapeutic intervention. That's why it's so important to measure stigma accurately. So the ISNI scale was developed to measure internalized stigma of people with mental illness. It has 5 subscales, and a high total scoring on the ISNI scale indicates more severe internalized stigmatization. So these are 5 subscales. Alienation, sought to measure the subjective experience of being less than a full member society stereotype endorsement, contains 7 items measuring the degree to which respondents agree with common stereotypes about people with mental illness, the discrimination experience, the social withdrawal, and the stigma resistance, which is the most important, as I think. The stigma resistant was intended to portray the experience of resisting or being unaffected by internalized stigma. PDD, perceived evaluation, discrimination and evaluation scale, measures felt stigma, which is the estimation how the society appraises people with psychiatric disorders and mental health users. And we know that stigma or negative self-beliefs could influence on anhedonia self-report. And furthermore, loneliness is also stigmatized, which creates additional challenges for patients indirectly acknowledging unmet needs for meaningful social connection. So that's why we decided to use our social anhedonia scale 2 with the Rechkova-Helmogorova questionnaire adapted version in Russian. So we examined 70 patients. Average age was 33 years. In accordance of their diagnosis, they were divided into 3 groups: F21 schizotypical disorder, F2 schizophrenia and schizoaffective disorder, and the 3rd group F2 and HIV infection. In table, you can see social and demographic characteristics of sample. We studied differences in the severity of perceived and internalized stigma, as well as social anhedonia among patients of the 3 groups. And we found that there were no significant differences in a SME score, but the bigger score of PDD was in the group of patients with concomitant HIV infection. Talking about social anhedonia, there was no any difference between mean scores, but in all of this group, the score were higher than normal range. Structure of the internalized stigma and its difference in 3 studied subgroups. We can see that alienation was higher in a group with a schizotypical disorder, and stigma resistance was higher in schizotypical in patients with schizotypical disorders too. As we expected, total score of BPRS was lower in a group with a schizotypical disorder, but there were no difference in BPRS between patients with schizophrenia, no matter have they HIV infection or no. We found correlations between social anhedonia and stereotype endorsement subscale, and between severity of psychopathological symptomatic and stereotype endorsement subscale. We see that number of hospitalization and duration of mental illnesses correlates with the stereotype endorsement, discrimination experience, and stigma resistance subscale. We know that some of our patients have more concomitant disease, and it means that they have burden of third stigmas. We know that some of subscales of BPRS scale correlated with PDD, SNE, and social anhedonia. So in conclusion, let's highlight the main finding. So comorbid HIV infection in psychiatric patients contributes to the psychiatric stigma structure. Patients with comorbid HIV infection showed increased level of perceived stigma, although they resisted the stigma internalization better than others did. Patients with schizotypical disorder and patients at early stages of HIV infection experience the most alienation and frailty to internalization of stigma. The correlation between social anhedonia and level of self-stigma in general and each of its cluster was revealed. The correlation between social anhedonia and perceived stigma was found only in patients with comorbid pathology. So HIV-infected individuals with high social anhedonia showed a more intense perception of public stigma and had more pronounced clinical signs of mental illness, especially the conceptual disorganization and emotional withdrawal. So comorbid pathology may alter structure of stigma and should be considered in development of destigmatization programs. Thank you.
Thank you. Any questions?
No, they tried.
One question from me. What approaches do you see to reduce the stigma?
Just to make patients' life better, to improve quality of life, to make it easier to get their treatment, I mean HIV treatment and treatment from mental illnesses, just to make them feel free. Mm-hmm. I know it's really open answer, like I'm humanitarian and not a doctor, but I really feel this way.
And to include them in different studies, yeah?
Why not?
Okay, thank you.
For self-esteem.
Yeah.
Why not?
Thank you very much. Any questions more? No? Okay, thank you.
Thank you. Dear colleagues, we have made all our plans with program, and I'd like to ask my colleagues to say some words about today's experience with our symposium. So who can start?
It was very interesting presentation. It was really, for me, much more interesting than usual Russian conference. So thank you very much. One point that I want to speak about is collaboration. Sometimes I see that lots of studies which were presented today easily can be shared with colleagues. And we, as Young Society's consular of Russian Society of Psychiatrists, we are interested in it, and we have resources for it. So first of all, you can connect to our Telegram channel, Smurop, and there will be, you can see all announcements of our presentations. So we will speak about different interesting things. For example, at 25 May, we will speak with my colleague, narcologist, about how the psychiatry and oncology is connected, and we will speak on 3 cases of real patients. Some of these patients we shared with my colleague narcologist. And we try to conduct very interesting themes that are not usually used and studied in the university in residency. And also by these connections, you can find collaborations. You can share your research and make much bigger samples of patients. And so your research will be much more interesting for journals, big journals, and it will give more interesting scientific results. So don't sit you alone. Look for collaborations. We are open for it. You can connect with Mikhail, and you can also connect to our sessions by the Telegram channel. And we are open for work with everybody.
Thank you. I also want to thank all of you for this symposia, because it was a great pleasure for me to hear and see you all today. Themes were really interesting, and questions were too. And for me, it was such kind of challenge, because actually it is my first time to offline speaking English with a big speech, big theme, and not only just MP3 file to e-post the presentation. I think it's very, it's a great opportunity, and it's a great experience for all of us, and I hope that we will retry it, and we will make it wider, bigger, and for a long time, far. So I welcome you to our Young Scientist Council Department of National Center of Psychiatry and Neurology, named after Bechtereva. Please go on to QR code and follow us and participate in all the activities, symposiums, and our regular meetings each month, each third Wednesday each month. You're welcome, and thank you.
For me, it's a great pleasure to make this this plan like a true for today. It was a real big challenge, and I think that we have deal with this challenge. I think that we had today a fabulous audience, fabulous atmosphere, a lot of questions, wonderful studies, very much research designs with multi-center studies, with longitude studies, with studies combining biological, psychological, psychopathological points of view on our patients. And I agree with Sergey that this is very interesting, and for me much more interesting than other types when there is no discussion about our research during the symposia. I think that we'll try to continue our way to make such discussion. And also, I think that we should continue our collaboration. We have a lot of opportunities to make this together. Nowadays, we are starting new research on residents in psychiatry from different cities and different countries in our National Medical Research Center for Psychiatry and Neurology, named after Bechtereva. That would be a very interesting longitudinal study. You can find this study in our social media, Telegram, VK, all other channels also. Welcome again on our next activities, and I hope that our collaboration with Russian Young Scientist Council of Russian Psychiatric Association will continue.